हेलो हेलो हेलो। हेलो हेलो।
morning, ladies and gentlemen, and welcome to our training of trainers event on antibiotics. It is a pleasure to see such diverse and enthusiastic group of healthcare professionals gathered here, all committed to enhance their knowledge and skills in the critical area of medicine. Antibiotics have been cornerstone of modern medicine, saving countless lives and enabling treatment of previously incurable infections. However, with the growing threat of antibiotics and resistance, it is more important than ever for us to stay informed about the latest developments, best practices, and emerging trends in antibiotic use and stewardship. Today, we have assembled a panel of esteemed experts who will share their insights on various aspects of antibiotic therapy, who aim to equip you with the knowledge and tools necessary to make the informed decisions in your clinical practice. Once again, welcome, and let's have a productive and inspiring day. Thank you. Now, I welcome Dr. Bhaskar Shenoy, Head of Department Pediatrics, Chief of Pediatric Infectious Diseases Division, Manipal Hospital, Bangalore, to provide us with the overview of TOT module.
Very good morning. It is always a pleasure to come to Dharwad with the great hospitalities of Dr. Vijay Kulkarni. It is maybe this college, third time I'm coming, and every time the degree of hospitality has increased, and I don't know how this multifaceted person finds time in getting hospitality also in addition to his routine work. So it is and in my alma mater is just next, so it is always a pleasure to come here. We have assembled here for the TOT or the workshop on ABC of antibiotic. We all know that antimicrobial resistance is a growing threat. It is not only the medical professional, it is the others in the society are also equally responsible for this threat. Doctors, of course, should be in the forefront to prevent that. Parents, over-the-counter medications, not completing the course of antibiotics, self-medication, all those things. And neighbor's child had respiratory infection, he was given amoxicillin, and this child, she also becomes a mini doctor and gives. So these are the various things that we practitioners have always seen that. Second, the pharmacy. He will give the medication on oral instruction by the parent. Third, the unethical promotion of certain molecules and combinations is also equally bad. O2, ofloxacin with ornidazole, one of the most hated combination that I see. Azithromycin with the cefixime. What rationale it has? And that leads to unnecessary burden on the microbiome. When it comes to the medical professional, we should be using the antibiotics more responsibly. And the Indian Academy of Pediatrics has formulated the modules. First was the rational antibiotic module by Dr. Vijay Evale, which went across the country, and definitely it has made a substantial impact on the sensitization of practitioners on rational use of antibiotics. Then came antimicrobial resistance prevention module. We also have an infection control module, because in antimicrobial resistance control, these are all the factors. It is not only your responsible antibiotic therapy is the only answer. The infection control is also important. We have become masters after COVID in infection control. But we are forgetting that. We should stick on to that, and these things will definitely help in reducing that. And when it comes to the antibiotics, we need to use responsibly. Antimicrobial rationality means, it doesn't mean that you should not use antibiotic. You use the antibiotic when it is needed. Don't use the antibiotic when it is not needed. Second, use an appropriate molecule for that. We have seen cefixime being used for otitis media. What rationale it has? Cefixime is not the panacea of all cure. You use it in a UTI. You use it in an enteric fever, but not in otitis media, where the bug will not act on that. Similarly, we need to know the antibiotic molecule also. And this is one of the unique module. May look like a pharmacology class, but it has been made more interesting. The basics are given. The pharmacodynamic and pharmacokinetics, how it helps in rationalizing or appropriateness of the antibiotics. The individual antibiotics, not in detail, but in gist. So that will help, especially all the pediatricians across the country, to know their antibiotic which they are using. KYC, for everything have a KYC, isn't it? So similarly for antibiotic, we should have a KYC, wherein you should know your antibiotic. And the other thing is, catch them young. And especially the postgraduates, if you catch them from this stage, definitely they become a rationalist in the antibiotic prescription. So having said that, this particular module was not an overnight job. It has been churned out by great personalities like Dr. S. Balasubramaniam, which all of you know, I need not tell anything about him. Great teacher, great academician. Dr. Jagdish Chinnappa and Dr. Jason Unni. And meantime, we have young Turks like Sri Krishna, who have been instrumental in making this more beautiful module. And I still remember last 1 year, I was fortunate to be a part of this module. Day and night we sat. Night 9:30 to 12 o'clock we used to have online meeting to make it more churned, take opinions from everything. So what I'm trying to tell is that this is not an overnight module, which has become the effort of all the brains put together. So having said that, definitely this module is going to be a boon. And once you go through the module, please try to revise it. Because once if you hear, it will evaporate and sublimate. But if you read again and discuss, it will percolate into our grey matter. So, just because as a formality doing a module and getting out doesn't serve any purpose, it should have a benefit on the practice. Ultimately, it is the patient, parent, the child, and the society should be benefited. That is the thing. You may think that it is a pharmacology class, but definitely case scenarios are given, and on that basis, it has been made more lively, and it has been made more interesting for the audience. Thank you so much. Have a wonderful learning. Thank you.
Thank you, sir, for introducing us to the world of antibiotics. I kindly request all of you to attend the pre-test, which has been sent as a Google form in the group. I welcome Dr. Sri Krishna Jian, Professor AJ Institute of Medical Science and Joint Secretary of IAP Karnataka State, to discuss about the classification of bacteria.
Good morning, everyone. So, after the introduction given by our Bhaskar Shane sir, so we will be starting with the module. Simultaneously, I think the pre-test has been given to all of you in the Google, in a WhatsApp group which has been formed. So, kindly fill that Google form. So, we will be starting with the first session. So, actually, we have divided each into two sessions of 20 minutes each. So first one will be your classification of bacteria and mechanism of action, which will be taken by your Singaravelu sir. So here we will be in next 15 to 20 minutes, we will be just having one brief overview of classification of bacteria, how we classify that, and we have some case scenarios too, and how to approach our case. So yeah. So what are bacteria? So I'll take you to little bit of microbiology, little bit of pharmacology, along with the clinical applications. So bacteria are microorganisms which are having only one cell wall. We can have the figure there. You can see the figure there. So bacteria may be harmless or harmful. We are worried about your pathogenic harmful bacteria. So this is the structure of a bacteria. So it has your outer cell wall, cell membrane. It is devoid of nucleus. It has a chromosomal DNA, double-stranded DNA, and it has some extra chromosomal appendages also, like flagellum, spores, all those things, depending upon your bacteria. So this is the brief view. So these are the microbes which lack a nucleus. So do you have any PGs here? Yet to come. Okay. So what is this basically? What we can make out here when we have a closer look. Okay, it is actually a, what is it? Anyone can tell me? Pardon? Yes, good. So basically we are dealing with a gram stain here. So this is a actual case of this is a gram stain of a 6-year-old girl who presented with high grade fever, with headache, with vomiting, found to have neck rigidity. So basically we are dealing with meningitis. Okay, so why it is important to know clinical history, all those things, we should know what organism we are dealing with. We are dealing with gram positive, gram negative, because our treatment will vary depending upon the organism. Duration of treatment also will vary. And here we require good support, though we see in our side labs and all a little bit, but we should need a good backup of good pathologist and good microbiologist. So definitely with the identification it will help us to plan the course of our treatment. So here we called our microbiologist friend, and so here, as madam already told, this is what we can see here. In the later slide we are having 1 or 2 slides about gram stain, like how does gram positive look, gram negative look. Okay, so pink color means gram negative. Okay, they have undergone decolorization and they have taken up the counter stain. So this is a gram negative diplococci. So we are dealing with your Neisseria meningitis. So this is gram negative diplococci, and our culture has shown gram negative diplococci, Neisseria. So with the appropriate antibiotics, the child was cured. So this was regarding our first case. So coming to audience question, like how do you classify bacteria? Yes ma'am, gram positive, gram negative, correct then? Yes, we can classify according to the shapes, rods, bacilli. We can classify according to gram stain, atypical bacteria we have. Okay, so this is the classification. So we have gram positive, gram negative, then we have anaerobic, atypical organisms, then we have cocci, we have bacilli. Again we have subdivision there. Then we have gram negative classification, cocci, rod, bacilli. Then we have lactose fermenter, non-lactose fermenter. You can see it goes on. So this is a brief classification of bacteria, and atypical bacteria are mycoplasma, your all other things. Okay, so this is the brief classification of our bacteria. So this is according to the staining. Okay, we have gram staining and Zinn-Lenston staining. Okay, gram staining is a differential stain. We can identify positive, negative, gram variable, and some don't have a cell wall like a mycoplasma. I think one of your MCQs has a question which does not have a cell wall. So another classification is your Zinn-Lenston staining for your acute fast bacilli, mycobacterium. So these are the different ways by staining methods we can classify our bacteria. So this is the gram stain. So here you can see two figures here, one at the top and one at the bottom. So one is a gram positive organism, other is a gram negative organism. So I told you your gram stain is a differential stain. So basic principle is we use a stain, crystal violet, which is usually a violet color. Then we fix the stain, then we decolorize the stain, okay, and then we use a counter stain. So your gram positive, there are some differences between gram positive, gram negative bacteria in the sense they have thicker cell wall, many other things and so forth. So this gram positive bacteria, they resist decolorization. So they are not decolorized. So they have their violet color, first color, they preserve that thing. But our gram negative bacteria are decolorized and they take up your counter staining, which is a pink color. So next 4-5 case scenarios, there will be a slide. We have to identify first whether it's gram positive, gram negative, and then go on from there. So this is your blue or purple retaining stain. Then destaining followed by counter staining. Pink or red is your gram negative bacteria. So this is one more classification of bacteria based on our shape. I think we can see there based on spherical bacilli, rod-like bacilli, spiral bacilli, comma-shaped bacilli, corkscrew bacilli. So these are something which you need to know. Sometimes we can make out. If you go to pathology or microbiology, you can identify and prompt treatment can be given. So now we will go to a second case. So here we have a 18-day-old newborn baby who has presented with umbilical redness, discharge from umbilicus, excessive crying, poorly accepted, baby is not feeding well, and there are episodes of crying. So how any of our PhD graduates come here now? Yeah. So I have the bad habit, man, of asking questions to PGs. Okay. So kindly can you stand up? Yeah. So what are your thoughts? You have seen this case, right? So what all comes to your mind when we presented with this case? What all you want to do? This is an 18-day-old neonate baby. So presented with umbilical discharge, then baby is crying excessively, baby is not accepting feeds. You will counsel them and send home, or you want to do something else? You need to monitor the baby more?
We can send for blood culture, pus culture.
Yes, very good. Okay, very good. So we first need to admit this child. We have to do a full septic workup in this baby. It is a small baby, less than 3-month-old baby. So we need to do a full septic workup. As you said, we are dealing with, basically we are worried about septicemia. We will lose the baby in minutes, seconds if we don't act properly. Okay. So and on continuation on examination, there is erythema, induration, oozing from umbilicus. Then we have high heart rate, high respiratory rate, abdominal distension, but AF is leveled. So we, as you said, we have sent a swab and we have sent a full septic workup. Since it is a smaller baby, we have done a LP2 and prophylactic empirical antibiotic we have started. So our provisional diagnosis is umbilical sepsis with septicemia. So what are the organisms which can cause this?
Staph aureus.
Yes, you can sit. Okay, so basically staph or staphylococcus is the most common organism, but sometimes you can have polymicrobial occurrence too. Okay, so staphylococcus, streptococcus, then gram negative, sometimes anaerobic organism, everything will be there, but most common organism is our staphylococcus aureus. So I think we'll come to next girl. Yeah. So this is the gram staining, this is the swab staining. You have taken the swab from that area. Okay. So what is this? What you can make out? What is the color of your thing? Two things I told you, no?
Yes, sir.
One is your crystal color or a blue color or pink color. So this is gram positive or gram negative?
Gram positive.
Yes. Gram
Cocci
positive.
in pairs we can
Pardon?
say. Gram positive coca in pairs. In
Yeah,
clusters.
more than pair, it is in clusters.
Clusters.
Okay, so it is like a bunch of grapes. Okay,
Yes.
sir has given us very good breakfast now, so not hungry. Otherwise, this looks like your bunch of grapes. So basically, we are dealing with your staphylococcus. Okay, so Yeah, so sit. So this is our second case. So where your umbilical sepsis, septicemia with your growth of staphylococcus. So now we'll move on to the third case. Okay, we have around 5 or 6 cases. Okay, so this is the third case. Who is the next PG there? Yeah. So we are having a 2-year-old child who presented with high-grade fever, flushed appearance and impetigo. Baby is lethargic. On examination, baby is having 30 pulse. Basically, child is in shock, high fever. We have sent a workup with the blood culture. We have started IV antibiotics too. Okay. So what do you think? What is happening here? Child is having impetigo. What is happening here?
Toxic shock syndrome.
Yes, very good. Okay. So here we are dealing with the child with the suggestion of toxic shock syndrome. So what is the causative organism?
Staph aureus.
Streptococcus. Okay. So this is toxin producing your streptococcus. So we are dealing with your mainly caused by Streptococcus pyogenes or Staphylococcus. Okay, so this is our gram stain. So what can you make out here? Gram stain? Gram positive or negative?
Gram positive.
Yes. Here, like before, it was like a branch of grapes. Here you can make out in the chains. Okay. So here we are dealing with streptococci. Okay. So this is a swab culture and blood culture of this child, which showed group A Streptococcus pyogenes. Okay. So then we get a sensitivity pattern 2. Then it is easy to manage. But this is a child streptococcus with toxic shock syndrome. So this is little bit about your toxin producing bacteria. Basically, we have exotoxins, which are super antigens, which are produced by your staph or your Streptococcus pyogenes. Then we have endotoxin, which is produced usually by your gram-negative bacteria. Usually gram-negative bacteria, if you see the cell wall, they have lipopolysaccharide membrane, all those things. Okay, so usually we have endotoxins produced by gram-negative bacteria. Then we have other toxins like your Shiga, cholera, and anthrax, which produce type 3A or B toxins. Okay, basically all this toxin mediated, they cause your cytokine storm. Okay, so we are worried, so we need to act early. Appropriate dose of Miro, Vanco, clindamycin, all those things has to be given, and once the sensitivity pattern we get, we can always de-escalate or escalate depending upon a condition of the baby. So we'll go to our next case. So we have a 8-year-old boy, complains of high-grade fever, throat pain. I think this is a common thing now we get usually. So throat examination has revealed this one. So what are the differential diagnosis and how will you confirm the diagnosis? Next. So here throat pain, fever, all those things we have. So what are your thoughts? What is your thought process? What all goes to your head when you see this case?
Probably having pharyngitis.
Yes. Okay. Can you be little more specific?
Most common streptococci.
Yeah. Okay. Then what are the other things?
Can be having tonsillitis.
Maybe bull neck, all those things are there. We are worried. Okay. Diphtheria, we are worried. What are the other causes which can cause all these things?
Viral. Epstein-Barr virus.
Okay. Okay, so as you said, Streptococcus pyogenes, group A Streptococcus, then your Moraxiella, which can cause, then diphtheria, then this is a common organism, Arcobacterium hemolyticum, Mycoplasma pneumoniae. So what can you see the gram stain there? What do you make out in that? Positive, negative?
Positive.
Yeah, and you can see the shape. Okay, you can see some gram-positive bacilli club-shaped, okay, in clumps. Okay, so we are dealing with your Corynebacterium diphtheria. Okay, good. Sit. So next we have dealing with the fifth case. So we have a 4-year-old child who with a perforated appendix with shock. Okay, started on empirical antibiotic, underwent emergency laparotomy. So this is the peritoneal fluid. So what it is showing? This is open for all. You can positive, negative. Yes, definitely. This is the gram-negative rods or bacilli, which you can make out here. Okay, little bit of classification of your gram-negative bacteria. So Coccobacilli, we have other influenza, Pasteurella, all those things will be there. Some more classification: gram-negative bacilli, oxidase positive, oxidase negative. You can see there we have lactose fermenters, all those things. So just sensitize these things. That's more than enough. So we are also worried about anaerobes causing infection. So your oral, abdominal, pelvic cavity sites may be involved. Other sites will be head, neck, skin. So most common anaerobic implicated in abdominal infection, as Bacteroides fragilis, followed by your Lactobacillus, Fusobacterium, all those things. So these are also one of the important causes of your liver abscesses. Okay, this is regarding your anaerobic causing infection. This is here we are dealing with classification of bacteria based on oxygen requirement. So we have obligate aerobes. Here they require oxygen. Without oxygen, not possible for them to grow. Then they have obligate anaerobes, which obtain energy through fermentation and use organic compounds as their terminal electron acceptor. Then you have facultatory anaerobes. These are neither here or there, means they can grow in the presence or absence of oxygen. Example being E. coli. So these are all based classification of bacteria based on oxygen requirement. So this is our last case. So we have a 13-year-old boy who presented with fever for 4 weeks, daily documented. Then we have cough for 4 weeks, then daily persisting with sputum, no hemoptysis. There is significant weight loss in this child. Okay, so I think this is a clear-cut diagnosis. Correct? We are dealing with pulmonary tuberculosis. So we have got an X-ray of our child. So we can see non-homogeneous opacity. We can see a thick walled cavity. Then we can see some areas of consolidation too. Then mostly we are dealing with TB here. So what next? What next has to be done? Sputum examination. Okay, CB nat here, but AFP we have sent. Okay, AFP showing, one second, acid fast bacilli of Mycobacterium tuberculosis. In your that time we saw 2 types of staining, right? Your Gram staining and Ziehl-Neelsen staining. Here we detect your acid fast bacilli of Mycobacterium tuberculosis. So this is about your Ziehl-Neelsen stain. So it is a rapid, inexpensive test for tuberculosis. This acid fastness is related to your mycolic acid in the cell wall. Only problem with this, we cannot detect resistance. There we require your expert. Here you can only identify organism. Then we can also detect your other antium, lepre, all other things also we can detect. So this is our last slide in this set of topics. So this is a summary of classification of bacteria. So till now, bacteria has been classified according to a phenotype, like including your size, shapes, staining properties, biochemical properties, since the beginning of microbiology. In the future, definitely, genotypically, your understanding the pathogenesis will be definitely increased. We have so many PCRs, everything coming up. Okay, so that is the future of our thing. I think I'll stop here. This is our first session, which is the basis for our further sessions. Next will be our mode of action of antibiotics. It is related to this one only. I request our Vice President, Sir Dr. Singaravelli, to take over. Thank you.
Thank you, sir. That was an informative session. I welcome Dr. Singarvelu, Professor Vinayaka Missions Medical College and Hospital, Vice President IAP South Zone, to delve into the mode of action of antibiotics.
Lights off, please. Good morning to all. It's a great honor and privilege to be here with you all for an important module which was conceived under our IAP National Presidential Action Plan under the leadership of Professor G.V. Basavaraja sir. And the unique thing about us today, the person who was behind Dr. SBS, who is my mentor and my good friend, and our national chairperson of ID chapter, elect, none other than Dr. Bhaskar Sinha sir, who has come. Give a big clap to him. See, you are all very fortunate that a module committee member who was instrumental in bringing this module is here with us. And young, energetic, dynamic Sri Krishna, who is a national scientific convener who gave this topic previously, is there. Dr. Sujit is there. And your own person, Dr. Vijay Kulkarni, and other speakers are there. So I am happy to be here since yesterday afternoon, enjoying as our Bhaskar and I, who formed the exact platform, what has to be about this module. You postgraduates, it is a great opportunity for you, this module. So, entire day, there will be quite a lot of repetitions, but ultimately that will stick on to mind, because we are in the era where facing antimicrobial resistance. So as sir has given already how it has got evaluated over a period of years, and we are also forming in diagnostic stewardship also here, infection control, all three are clubbed in this program. And continuation of this, the mechanism of action of antibiotics. The basic thing, whenever antibiotic you see, first thing, when we go into pharmacology, what we all read, it is only a repetition, I will not be taking much time, a broader classification, whether it is a bactericidal or bacteriostatic, that is it. What is the difference between a bactericidal and bacteriostatic? Is there any superiority over, if it is a cidal, is it superior? Is it a static, it is superior? It is all. It is only how it is acting. Unless you know which are the drugs are bactericidal, which are the drugs are bacteriostatic. As sir was telling about irrational combinations. When you combine a cidal drug with a static drug, then the drug which is cidal will not be acting anything. It will act only when the anaerobes are multiplying. Then only it can kill. The bacteriostatic drug, which will not kill, which will paralyze, which will make the organism inactive. It doesn't mean that it is not a very simple drug, that also very effective, especially when the toxin producing organism, when they are interfered, then they will not produce the toxins. For example, inisolol and other drugs are there. So first thing you should know what is bactericidal and bacteriostatic. Bactericidal drugs are the drugs which are actively multiplying bacteria, any anaerobe. Bacteriostatic, which will control further progress, it will not kill, but once it is being not active, even if it is alive, it is not going to produce any impact. So that is bacteriostatic. You should know how these two things are there, for which you should know the basic thing. There is a ratio called MBO, minimal bactericidal concentration and minimal inhibitory concentration. Don't get confused much about it. If the ratio of the minimal bactericidal concentration to bacterial inhibition concentration, if it is narrow, then the drug will be more of bactericidal. When the ratio is widened, it will be more of bacteriostatic. This is a basic understanding. So that will be the bacteriostatic. And you should have in your mind, moment you see, that need not, because in your routine use, what are the common bactericidal drugs, bacteriostatic drugs? See, our good old aminoglycosides, let it be amikacin, gentamicin, whatever may be, and beta-lactam, which are in our day-to-day practice using penicillin, cephalosporins, and newer drugs like carbapenems, and quinolins, like ciprofloxacin, which are using right and left, and other drugs, glycopeptides, vancomycin, cyclic lipoprotein, which is called daptomycin, and our imidazole derivatives, our commonly which you are using our metronidazole and all that. These are all the bactericidal drugs. You should have some idea what are the common bactericidal drugs. Whenever you see a molecule, first you should think whether it is bactericidal. It doesn't make a difference in treatment, but it will make when you use multiple drugs in treating an infection, for which you should have some idea. And bacteriostatic is our tetracycline group, especially glycycycline. Tetracycline is the latest drug, and our doxycycline, which are using for atypical infections, and lincosamide, especially clindamycin, and our macrolides. So these are all other advanced drugs Though they are bacteriostatic, they are very effective because I told that linezolid, other things are, when especially an organism which are releasing toxins, when you control that, that will be more effective. Otherwise the patient will, sir has shown that situations, how toxins can produce other things and all that, and our linezolid and other sulfonamides. This is a basic fundamental classification you need. As I told you, which is superior, which is inferior, that is not a matter, because again a sidal drugs can be a static at a lower concentration. A static drug can be a sidal at higher concentration. Some drugs which are lower at a sidal, when you increase the dose concentration, it will become a static also. So various fluoroquinol insert drugs. There are extensive evidence that static agents, sidal agents are similar in efficacy, especially for common infection like skin infections, lung infections, common pneumonias, and other intra-abdominal infections, genital infections. So, your therapeutic advantage aspect, I don't say that bactericidal or superior static. You have to, this is a first fundamental thing you should know. Then next, based on his talk only, when I told the first classification, here we have the mechanism of action. Next, you should know how a drug works, which group of organisms. So, for which now whenever you do an investigation, when you prove that it is a gram positive, whether it is a cocci, bacilli, whatever it is, you should know the basic fundamental classification. Is it a gram positive, which he has very clearly explained, or negative, or anaerobic or atypical or spirochete. These are the very common, something even unclassified also was there. These are the major thing which you should be aware. Next, we are in era, and other thing, the bactericidal drugs usually will be active even in immunocompromised persons. So when a person is immunocompetent, bacteriostatic drugs are good. Especially immunocompromised patient, try to select the bactericidal among the best drugs, especially patient is neutropenic. But it is not again universal. These are all, when you think of a treatment, empirical treatment when the child is, you should know basic pharmacology, how the drug acts. Sarah has told, though it is more of pharmacology, but we are not talking much of theory, but without this, you cannot be a good proper clinician in treating. If you don't treat randomly, if you start giving antibiotic, we have now come an era that where there are no much pipeline antibiotics are there. We have to live with the existing antibiotic with efficient use, for which we should, as a clinician, should have a basic. Our India, we are still suffering over-counter drugs are being, say for example, azithromycin is being left and right, is given over the counter, which is one of the best drug to be kept in a resource category, because it is simple to use, single dose therapy, short duration, economical. So patient, sir, whenever they come with a throat infection, sir, last time I took azithromycin from a doctor, this time my child had, I gave azithromycin for 1 day, 2 days. This is a scenario for which we ourselves should be thorough in where to use, when to use. That for that only this, all these things we are discussing. So just it is going through, going to our how antibiotics are developed. Though we call it as microbes, they are all developed from the microbes only in various forms. Let it be a fungi, where the good old our penicillin in 1940s, where the penicillin was developed only from fungi and other cephalosporins. And certain things are, even the broader bacteria, even subunits of bacteria also, certain drugs like miprazin and other drugs have been developed. And from cholesterol and aztreonum from some bacteria it is developed. Actinomycin, you know all, many of aminoglycosides and tetracyclines, all these things are, this is just to have an idea, because initially it was for microbes. Then it becomes semi-synthetic, that is microbes along in the laboratory, where our extended spectrum of penicillin, say our ampicillin, amoxicillin, all these things are semi-synthetic. Now purely synthetic drugs have come, where linezolid, other things are synthetic. What is the advantage? See, when the synthetic drugs are coming, unless you properly use that, the chances of early development. See, penicillin, when it was developed, still we are using penicillin for certain infection which are good old. Whereas the recent drugs are quickly going to develop the resistance. So you should know how the drugs are, how from what source it has been produced. So with this, we will go to the mechanism of change. You need not mug up everything, you just know how all it can act, for which when you know about the bugs, then where the drug acts, so how it will be beneficial. See, it can be either any bacteria, he has beautifully explained the cell, where it will have a cell wall, which can be mainly the bacteriostatic drugs, where can inhibit the cell wall, or it can inhibit the cell membrane division, or it can interfere with the protein synthesis, or it can interfere with the nucleic acid synthesis. So any way it can act, the drug can act and can stop multiplying or killing, whatever way this is. These are all other things. So mainly the polymyxin group or interferes and daptomycin, this is cell wall, this is a cell membrane. These two drugs interface with the cell membrane. This is just for you to know, that's all. From cell wall, where the outer layer of the bacteria, where all our common drugs, beta-lactam, penicillin, cyclopeptides, cephalosporin, carbapenems, all this aztreonam, all this acts in the cell wall. Then next is acting on the folic acid metabolism. So this is very important because this sulfamethoxazole and trimethoprim, which interfere with the folic acid, which involves in two steps. First is dihydrofolic acid, second is tetrahydrofolic acid, where the sulfa and this trimethoprim. So that is why the combination of sulfamethoxazole trimethoprim was being used, because they will try to act at both steps, they will try to kill the organism. Or it can be, that is called the metabolic pathway. So it can interfere with the metabolism of this, then it can further, then it can include with the nucleic acids, where the DNA, RNA, especially the messenger RNA, where quinolones and other, DNA will be acted upon by quinolones, and enzomycins, especially the typical example is rifampicin, which acts on messenger RNA. Sometimes ribosomes, where 30 units and 50 units they are all called protein synthesis blockers. This is just for you to know there are various ways of action about various type of antibiotics. So the bacteria, the bugs can be attacked either at the cell wall, cell membrane, nucleic acid, or with the ribosomes, or in the protein synthesis, where you have 13 subunit, where you have tetracycline and other aminoglycosides. This is how the mechanism of action, and in a 50 unit comes the subunit, where in the ribosomes, where macrolides, clindamycin, linosylates. This is just an overview, don't think much about it. How all you should have some idea. When you prescribe a drug, we should know as a clinician the common drugs, what the mode of its action, the mechanism of action, you should know. Next most important is, this is very important because whenever you see antibiotic, whether it is hydrophilic or lipophilic, it means that whether it is water soluble or fat soluble, where it has more affinity to this. Because if you don't know this, in situation when you come across these drugs may be ineffective, or sometimes it may be very harmful also. Even the common drugs which you let it be a beta-lactam, where the penicillin, cephalosporin, carbapenem, meropenem, all the monobactams, all these things, aminoglycosides, these are all hydrophilic. It means that it will be distributed, it will not enter into the intraplasm, it will not enter say the intracells, cells it cannot. It will be getting distributed in the circulation, and it will act on the bacteremic phase. So these drugs will kill when the organism circulates. So you should know when the early stage of bacteremia, if you use those drugs, that drugs will be very effective. Once it has gone to intracellular pathogen, for example, tuberculosis, as Sarah has given, that certain drugs may not be active because it will not enter when hydrophilic drugs will not be used. But you should know it will have a large volume distribution, and as I said, unable to pass through this membrane and inactive against intracellular pathogens and eliminated because it will be excreted through the renal. So when the child is on diuretic, or child is on having a third phase, because now you are seeing lot of dengue, where the fluid will be last in the third space, where the child is also having sepsis. So when you give this drug, the drug, it has to be circulated through the volume, the dose may not be inadequate. Or when you use a diuretic, the drug will be excreted and changed in the renally. Or when the renal function is compromised, if you use the drug, it may produce the toxin. So you should know the advantages as well as the disadvantages. So it will be a decreased level during hyperdynamic state, especially cardiac failure and all that, and increase third space as you see in dengue and nephrotic syndrome, all these conditions. Second group of drugs are lipophilic. The very common drugs are macrolides, quinolones, and tetracycline, chlorphenicol, all these things. Because if you know this agent, then where it can be used, it is called large volume of distribution. It freely diffuses into the cells, active against intracellular pathogens, and when it goes into the cells, it will be excreted through the hepatic metabolism, not through renal metabolism. So you have to know if the child has got some problem. It is not only pediatric, even when we are taking some drugs, we should know how it is getting excreted. We have some biliary problem or hepatic problem. At those situations, we have to, when you use the drug, you have to be very careful, otherwise it will end up. This another way of classification. These are all just to know. See, there are different classes of antibiotic which is bactericidal or bacteriostatic. So you see, beta-lactam, you know all penicillin and extended beta, ESBL and all that you know, where when we talk about individual drugs, our learned people will be discussing a lot about it. I am just giving an overview in this topic. Then aminoglycoside, you know various aminoglycosides starting from a good old gentamicin, amikacin, all other things you know, and glycopeptides and ansamycin, where rifamycin, and quinolones, where even the latest quinolones who has come, and streptogamins. These are all, who are this color is or bactericidal. These sulfonamides, chloramphenicol, tetracycline, macrolides, these are all are bacteriostatic. The next most important part when you talk about the mechanism, you should, this very important, because what we are worried, why the whole concept of talking about this, we are in the era of antimicrobial resistance. Though we are talking much about that, we are celebrating antibiotic awareness week, all these things, various names were given. This module being, as I told, from starting from Vijay Avle and so many, every year, every president brings in a different names. But this module, they took all the shortfalls in the previous module. So they want to take you minimal basics up to the latest and how we evolve. So at the end of your day, definitely you all go with some idea, and whatever concepts we are having, we will unlearn and we will relearn. That is the entire aspect. This is the most important. Apart from this, you should know what is this aware framework means, where you should, A stand for where to assess the antibiotic. Second, it is accessibility as far as India is concerned, no problem. Even the costly drug, you can easily get into that. And you have to watch which situation you have to watch the antibiotic, and which antibiotic we should not use even if it is available, which has to be reserved for certain purpose, when it should be used. This is the main thing. When you are decided, when a child has come and doing an investigation, again I told you diagnosis institute where we have brought a separate module on that. For any child he has showed certain, because he showed very clear-cut cases. See, undifferentiated fever, child coming with fever for 2 days, child is active alert, had mild throat infection. Will you be doing investigation, pharyngeal swab for every child and waiting for the culture report to come? By the time either the pain would have gone, and having known the epidemiology of your own place where you are practicing, what are the common infections existing? So you should think of the common infection, you should start empirically. At the time you cannot be depending on the investigation every time every child a battery of investigation, because that investigation also can mislead you in a different way if the test is not properly taken, if it is not properly done in the lab, if you start reading the reports which is not correlating with your clinical symptom, then you are in doubt. So for which you should know when to assess antibiotic in the absence of any investigation, in the common clinical scenario where you think it is a bacterial, or where you are able to differentiate from the clinical examination whether it is a viral or a bacterial, then which antibiotic I can use in this situation. For which you should have, this is called, for which when you have decided to select an antibiotic, it should be economical for the patient, it should be cost effective, and you should have a narrow spectrum. You should not use a broad spectrum, because killing and this, you cannot use atom bomb for a rat. So you have to select an antibiotic which is very specific for that, and it is least potential for developing resistance, and the side effect should be minimal. All these things you have to take. You have to consider the patient, you have to consider the drug, you have to consider the bug. All three should come into line when you are selecting a drug accordingly. And sometimes you have to do for the empiric treatment, you are justified. Every time you cannot, I am telling the rational is not based on the investigation. Rational is your judgment, how you are rationally thinking the infection, how it is going to be. That is how. So for which there are battery of investigations, I mean drugs. You can assess any antibiotic. There is no concern in our place. We are not in abroad where even to get an appointment to a doctor is difficult, and to get an antibiotic over the counter, it is not at all possible. If at all, you can get only paracetamol. Other drugs you won't get at all. That is, but we are in a large diverse country where we have to have something. As a pediatrician, we should have some concern over the committed to our own children of future nation. So these are the drugs which you have to be very careful in taking a selection, and these are the drugs. There are so many drugs. Of course, still sulfamethoxymethoxam we are right and left we were using in our OPD in the government setup. Now still it has to be the best drug for all. So we have to select. So you should know what are the antibiotics which can, and which next group which you can watch the antibiotic which have a higher potential for resistance, and especially those drugs should be used for when the child is very sick, and whether it is hospitalized or the child is a very serious condition where you cannot wait for the investigation report. At those situations, you can use these drugs. These are called, we can call it as a second line drug. It doesn't mean that the drugs are sidelined. So these drugs should be reserved for certain conditions, or as I was giving a typical example, for a throat infection, giving a cefixime. Because cefixime is one of the best drugs. Always we tell below the diaphragm, always it is a better drug, whether UTI or enteric fever, the cefixime will be a better drug. So like the ceftazidime, ceftriaxone. So our SBS always used to tell, fever is not due to ceftriaxone deficiency. Any fever, people will start using ceftriaxone, because various brands freely available. It has got a wide spectrum of activity, but we are in the era where we are going to wonderful drug, we are developing resistance for them. So these are the situations where you have to watch with all these antibiotics, the battery of investigation. Then the reserve antibiotics, especially multi-drug resistance pathogens are there, and especially in ICU conditions, where child is in septic shock and other severe infections, which we as a practitioner, so we should know the limitation. If we are doing a general practice, when the child is not very sick, and what is our limitation in using antibiotic, we should have an oath ourselves, we should have a pledge on ourselves. I will not touch those drugs. If these things are, we will refer the children, let it be properly investigated, then we can use. Without investigation, without warranting clinical situation, assuming ourselves giving a higher drug will not cure the disease. It doesn't mean a good drug, a new drug, a high potent drug. It doesn't mean that the drug will act for all pathogens. Unnecessarily assuming when we are spending the patient, resources are getting lost. Second, our concern more than resources, we are producing resistance. So we have to think, and only in the last slide I can say, we as a practitioner, we should know our limitation. up to what level I am going to handle the baby. If the baby is so sick, severe infection, where I don't have the facilities to investigate and come to a conclusion, I will not handle. I will refer a place where they can do that. We will keep those antibiotics for that. Even we need not remember those antibiotics, which is need not be, because by knowing that, ordering that, it is not the correct way. So, for example, these are the drugs which has to be kept as on date, because other newer drugs are for a quite long time, it is not in the pipeline. So, ceftazidime, avibactam, and colistin, phosphate, these are all the drugs. I can enumerate because you will be dealing about each drug in subsequent. So, I don't want to take much of this. So, with this, here I have given, as a practitioner, you should know, whenever we write an antibiotic, first the basic thing you should know whether it's a sidal, static, what are the advantages, what is the mechanism, how it acts, and what groups it is involved, and which conditions, if one drug may be effective for so many conditions. So, when you are selecting antibiotic, so whether it is going to be a cheaper, less costly, and less side effect, narrow spectrum, these things we have to think it twice. So, before think more. So, when writing an antibiotic, you can write whatever it is. You can write multivitamins, other things, whatever is, so many things are available in the market where we are beginning. But when you are thinking of an antibiotic, so you have to be very, very careful in prescribing drugs, for which you should be very, only this module which is going to deal about you. So definitely next sessions you will be very happy. Welcome, madam. So with this, thank you for giving me this opportunity. And
ಗೊತ್ತಿರ್ಲಿಲ್ಲ ಟಾಪ್ ಅಷ್ಟೇ
It gives me immense pleasure to welcome you all to the inaugural function of our antibiotic training of trainers. This initiative marks a significant step forward in our collective effort to enhance the antibiotic stewardship and combat the growing challenge of antibiotic resistance. I now welcome the dignitaries on the dais. Our Honorable Chief Guest, Dr. Niranjan Kumar, Vice Chancellor, SDM University. I request Dr. Kavita to extend his warm welcome. Our guests of honor, Dr. M. Singarvelu, Vice President, South Zone IAP. I request Dr. Mahesh to welcome him. I welcome Dr. Ratnamala Desai, Principal, SDM Medical College and Hospital. I request Dr. Mahantesh Matti to extend her warm welcome. I welcome Dr. S.N. Moti, President, Karnataka State Branch, IAP. I request Dr. Satish to extend him a warm welcome. I welcome Dr. Shashikiran, Secretary, Karnataka State Branch. I request Dr. Shrikant Pai to extend him a warm welcome. I welcome Dr. Prashant, HOD Pediatrics, JSS Medical College. I request Dr. Shivanand Pai, Treasurer, IAP Dharwad District Branch, to welcome him. I welcome Dr. Abhijit Kulkarni, President, IAP Dharwad District Branch. I request Dr. Mithun to extend him a warm welcome. I welcome Dr. Bahubali Ingli, Secretary, IAP Dharwad District Branch. I request Dr. Divyashri to welcome him. I also extend my warm welcome to Dr. Vijay Kulkarni, Vice Principal, Head of the Department, SDM Medical College. Now I welcome Dr. Swati, Senior Resident Department of Pediatrics, for an invocation song.
गौरीनन्दन गजवदना गणेशवरदा मा पाहि गौरीनन्दन गजवदना गणेशवरदा मा पाहि गजमुख गणनादा गणेशवरदा मा पाहि गजानना 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 ॐ गजवदना गजानना ॐ गजवदना एकदन्ता गजानना हे रम्बा गजानना एकदन्ता गजानना हे रम्बा गजानना 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 ॐ गजवदना गजानना ॐ गजवदना गजानना ॐ गजवदना
So, I invite Dr. Srinath Mughali, past Vice President, please come to the stage. Vinod Tretagiri, Bhaskar Senai, please both of you, please come, sir. Come, sir.
I express my gratitude for the participation in the lighting of the lamp. I request Dr. Vijay Kulkarni, HOD Pediatrics, to welcome the gathering.
Good morning, one and all. Invoking the blessings of Lord Almighty Manjunath Swami, the revered, it's my great pleasure to welcome the August gathering for today. The monsoon has started. It's been a very dull Sunday morning. I extend my heartfelt thanks to all of you. You always want to be around the bed, especially on a Sunday morning, and we are asking you to come at 8:30. Nevertheless, today happens to be an important day because we are all surviving on antibiotics. And today there can be no other apt topic than the ABCs of antibiotic. So we are all enriching ourselves with some antibiotic stewardship at the end of today's program. This is the whole purpose of this TOT program what we are having today. Having said that, I extend my heartfelt thanks and I welcome our Honorable Vice Chancellor. Thank you, sir. sir otherwise daily is in the office till 7 o'clock. Sunday also we don't leave him. So thank you so much for your time today. Then I thank Dr. Ratnamala Desai madam. Madam again is very busy. Thank you madam for your time. Then there are host of luminaries. This function would not have been possible but for the IAP initiation. We are all proud members of Indian Academy of Pediatrics, and our Indian Academy of Pediatrics Dharwad branch is a very active branch which we are known throughout our Karnataka for our active scientific programs. And I extend my heartfelt thanks to Dr. Singarvelu sir, who happens to be the Vice President of South Zone. First time he saw yesterday our hospital, our campus and all. I believe he is very happy seeing our campus. Thank you once again for your... He in fact had to take a flight from Mumbai. He had been to North India. Almost 2 days he has been traveling for this program. Thank you, sir. Then I extend my heartfelt thanks to Dr. S.N. Moti, sir. Moti, sir, is our state president, Karnataka state branch. Again, sir actually has come yesterday morning to Hubli, but he has been visiting Bijapur branch, then Bagalkot branch, and finally he is visiting our IIP Dharwad district branch. I extend my heartfelt thanks to you, sir. Along with him, Dr. Shashikaran is a very dynamic secretary of the state. We welcome you. And we have a surprise today, Dr. S.N. Prashant. He is a young dynamic HOD of Pediatrics, JSS Medical College, Mysore, who is also a faculty. He has been with us here. And this program would not have been possible but for the stewardship of IIP President Dr. Abhijit and Bahubali. And so many backhand things are done. Actually, I thank and congratulate our Department of Pediatrics. Everybody is involved in this program. I thank them heartily for putting all their effort from last 1 week for the smooth conduct of this program. A word of thanks to Dr. Vinod and all the team members, all my postgraduates for taking out their time. Finally, but not the least, the private practitioners, probably they will be joining us. I also thank the Department of Microbiology, the Pharmacology, and the other department postgraduates. There is not a department where antibiotics are not prescribed. So in general, this program would be beneficial to one and all. Thank you so much. Thank you.
Thank you, sir, for the warm welcome. I request Dr. Abhijit Kulkarni, President IAP Dharwad, to introduce and felicitate the faculty.
Good morning, dignitaries on the dais and off the dais. It's my privilege to introduce the esteemed faculties for today's TOT on ABC antibiotics. First of all, I would like to call Dr. Bhaskar Shinoy, sir. He is the current head of Department Pediatrics, Chief Pediatric Infectious Disease Division, Manipal Hospital, also adjunct professor of Pediatrics, Manipal University. I would request Dr. Niranjan Kumar, sir, VCs, to honor sir. The positions held by sir is he was honorary secretary Pediatric Infectious Disease Chapter 2023, chairperson elect. He is joint secretary Indian Academy Society of Kawasaki Disease. He is managing editor Pediatric Infectious Disease, editor in chief Karnataka Pediatric Journal. Now I call upon Dr. Sri Krishna Jian. I request Dr. Singarvelu sir to felicitate him. Dr. Dr. Sri Krishna, he is Joint Secretary of IAP Karnataka State Branch 2023-24, National Coordinator of ABCA Module 24, and IAP Dakshina Kannada Branch 2022. I call upon Dr. Sandeep Kumar BK, the next faculty. He is Associate Professor, Department of Pediatrics, Kasturba Medical College, Manipal, Udupi. I request Dr. Ratnamala Desai Madam, Principal, to felicitate sir. Now I call upon Dr. Vinod Atagiri sir, our own. He is the Professor of Pediatrics and Head of Department of Pediatrics, KIMS Hubli. I request Dr. S.N. Moti sir to felicitate Dr. Atagiri sir. I now request Dr. Vijay Kulkarni sir, the faculty, to be felicitated by Dr. Sashikiran, the Secretary of Karnataka, IIP Karnataka. Sir is Vice Principal as well as HOD Pediatrics, SDM Medical College. Thank you, sir. Thank you, sir.
Thank you, sir. We wish to honor Dr. M. Singarvelu. I request Dr. Niranjan Kumar, Dr. Abhijit Kulkarni, Dr. Bahubali, Dr. Vijay Kulkarni and Dr. Vinod Chauhan to do the honors.
Sir is currently the IIP Vice President, South Zone 2024. He's the Vice President. He has been the Vice President of IMA TN State in 2022. He's the winner of various prestigious awards such as the Maruthuva Nachatra Award by the Honorable Health Minister in 2021, the Jayaraj Ayyanadar Oration Award, the Mamannan Rajarajan Award and the V. Balagopala Raj Active Pediatrician Award. He's been received the prestigious Sarvapalli Radhakrishnan Lifetime Achievement Award for the Best Teacher. He's also received repeatedly the Best Doctor and the Best Teacher Award. And Dr. Jaya Memorial Award and NSVMC Oration Award. These are some of his awards to his name.
I request Singarvelu sir to address the gathering.
Good morning to all. It is a very pleasant occasion, I can say, in my life. Since yesterday afternoon, the time I landed Hubli, Dharwad, I'm enjoying the hospitality of SDM University, the HOD of Pediatrics Vice Principal, none other than your own Professor Dr. Vijay Kulkarni. His meticulous planning under the leadership of Abhijit and Bahubali, the President and Secretary, and my mentor of State President, Dr. Moti, Sasikaran, and my good friend Prasant, and leaders, past leaders, Vice President of our National South Zone, my predecessor, Dr. Srinath Magali, my good friend Vinod, and today's module speaker, Dr. Bhaskar, Sri Krishna Dynamic, Sujit and all others, and our principal madam. But yesterday, our Vijay sir took me. I want to take only 2 minutes, though we know that during scientific session, our Vice Chancellor was telling it should be very short and brief. Such a great academician, but I cannot stop talking at least few words how this institution, which I could really enjoy, because I have been in teaching institution more than 4 decades. I have traveled extensively to so many institutions. I have been an advisor and so many things. But what I could perceive, it is a private medical college, because first time coming, I didn't have any background idea except I knowing about Vijay Kulkarni, Srinath Mughali and Vinod. So nothing else, sorry to say that. But after entering, seeing the building, so they have good infrastructure. But going into the ward, see, such a wonderful department. And your HOD was telling all about the management. Everybody will praise about the management, but talking much about Vice Chancellor and the principal. And he was going all for everything, sir, you are doing a department very extensively well. And he was telling, no, sir, our Vice Chancellor is helping and all that. Then I got, sir, I want to meet him. Unfortunately, I could not at that time, sir was not there. So we were about to leave after visiting the department. I will not take much travel to him. So when I was leaving in the car, sir said, our Vice Chancellor is there. So immediately, sir, we will meet him. And we got down. So where is he? He is not there. He was showing a person who was perceiving along with workers, seeing the granite stone. And then I went and, sir, I have not seen to this granite stone for my own house, a Vice Chancellor. Then by the time I heard about his background and all that, he is known to my close friends, family and all that, then I spoke to them all. Then he and madam, both them took their office, and what a wonderful person, sir. Really, sir, it is because with heart, great heart, I am telling, what I could pursue, how this institution within 2 decades has developed in such a way, the meticulous planning. We are really proud to be here, and we are happy that this program of our Central AAP being conducted here with these great persons. And madam was telling all about SDM, that great Manjunath Ishwar, with his grace, with his blessings. I am sure that the great people who are doing with a lot of, because I have been in the government institution where I could see workload. I have been working in a various private medical college also over a period of time. But this institution doesn't look like a private institution. It's more than, I can say, the government with corporate setup where all infrastructure facilities. Hats off to you. Why I'm telling, it is not question of money. It is a question of dedication. So really, on behalf of our National AAP, under the leadership of our President Basavaraj and our team of OB members and the past leaders of IAP here, with the divine blessing of this, I wish that under the leadership of sir and madam and all the chairman who was given the full liberty to develop as they like, and the individual process, each and every person I met. Went to the human milk bank. I really wondered. I did in my institution 9 years back. But what a wonderful, say, I thought, sir, oh, they have money, then I just opened the fridge. I could see the volume of load of milk. It is not, really, sir, I have to appreciate the leaders, the HOD and the thorough hospitality. Thank you for giving this opportunity. And thank you all the IAPNs, all the postgraduates and all the faculties of the department for giving me this wonderful opportunity to visit. And thanks, sir, Vice Chancellor, sir, such a wonderful person, sir, I met in my life. That is more important. And my good friend, Srinath Mughali, who gave a very good hospitality with Vinod and others. Thank you for giving me this opportunity.
We would like to felicitate Dr. S.N. Moti I request Dr. Niranjan Kumar, Dr. Abhijit Kulkarni, Dr. Bahubali Ingile, Dr. Vijay Kulkarni, and Dr. Vinod Chauhan to do the honors. Sir is consultant pediatrician of Kid Care Clinic, Mysore, founder trustee of Asha Kiran Charitable Trust and Charitable Trust Hospital, Mysore, and Mysore Adolescent Health Academy. He is also the president of IAP Karnataka State Branch. I request Sir to address the gathering.
A very good morning to everybody. Recognizing the presence of our Vice Chancellor, Dr. Niranjan, Madam Ratnamala, and Dr. Singaravelu, our National Vice President, Dr. Shashi Kiran, and Dr. Bahubali, and Dr. Abhijit, and of course, Vijay Kulkarni. And I bring warm greetings from Mysore on behalf of all of us, and Dr. Prashant and Gurraj also is there. And I do recognize the presence of our distinguished faculty who are making this day's learning extremely interesting and worthwhile taking as a message. And at the very outset, I must say how humbling in experience it will be whenever we come to Hubli Dharwar. I must say it started with the aroma of filter coffee in Dr. Srinath Mughali's house yesterday morning, and the warmth and affection that was so heart-touching. We spent a couple of hours, then we went to Bijapur, and then also we were able to go to Bagalkot and address the IAP groups, and today we are here. At the very outset, I regret that we arrived here a little late. Kindly forgive us for this. Okay. And I must appreciate the efforts of our faculty, Dr. Bhaskar Shennai, Vinod Ritkari, Sri Krishna, and the entire team. All of them put in their heart and soul to make sure this could have been just a module which is given to all of you, the hard copy of that, to bring in their learning, their experiences, to make it more impressive is what makes this presidential action plan very special. And we know for certain how Dr. Basavaraja and Dr. Singavelu, Yogesh Parekh have put up these various workshops so that the effort of reaching out to all the 45,000 pediatricians across the country so that their voices and their efforts and services could reach out the over 1 billion population of the country, which is something which is unprecedented, and this has been possible because of our great visionary National President, Dr. G. Basavaraj. And I must say today's topic especially, ABC of antibiotics in the background of emerging antimicrobial resistance world over, which has become a concern because it is emerging as one global problem. We were talking about HIV, TB, malaria, which were taking a lot of lives. Now we get to understand AMR has become a problem not only in the third world countries, low middle income countries, it's become a huge problem even in the developed countries, causing concern because in the last 2.5 decades, there is not a single new antibiotic in the pipeline, largely because the shelf life of antibiotics is very short-lived. Research and development to bring out one new molecule cost in excess of $1 billion. But we get to understand even the antibiotics which are there, within years after they are introduced into the market, we come across AMR, antimicrobial resistance. That's why research and development, they put their money on anti-diabetic drugs, anti-hypertensive drugs, which have got longevity to survive and to bring in a lot of revenues. These are some of the concerns, consequent to which we as clinicians have a very designated and important role to conserve the availability of the antibiotics and use them very judiciously, so that at least we do not contribute to the worsening of this antimicrobial resistance, a problem which has been causing global concern. Even India is waking up to this concern, consequent to which a lot of efforts are going on at the national level, and I'm very sure IAP also will play a big role, along with, like what was said, having microbiologists and clinical pharmacists in the entire effort in day-to-day clinical management is going to be a very huge step, which will help us very judiciously pick up the antibiotics. I'm very sure the whole day's learning will get you a lot of meaningful information in this regard. And on behalf of Mysore, my friends, I once again thank you, and I must tell Dr. Vijay Kulkarni, it's always been a very humbling experience when we come, like what Dr. Singaravelu said. If I could describe this entire institution in a single sentence, I would say, this is a temple of learning. And this is possible because the holy background from which this institution is being conceptualized, and what kind of people are there who are taking forward, bringing this dream institution to its reality and have it going with the same passion, same intensity. I wish the institution and all the forefront leaders, Dean Madam and the Vice Chancellor, carry forward this legacy and make sure this temple of learning continues to glow and continues to throw its light and impart messages to all the youngsters so that they will carry the legacy forward. Thank you immensely.
Thank you, sir. We are immensely happy to have you here. We would like to felicitate Dr. Shashikiran, Secretary IAP Karnataka State Branch. I would request Dr. Niranjan Kumar, Dr. Abhijit Kulkarni, Dr. Bahubali Ingri, Dr. Vijay Kulkarni and Dr. Vinod Chauhan to do the honors. I request sir to address the gathering.
Very good morning, respected dignitaries on the dais, and the esteemed IAPNs of Dawa district branch. I recollect my memories in the same hall as a student in Kim Subli. I have visited multiple times. My actually career as a pediatrician started from this place. So during the initial stages, I have looked up to leaders like Srinath Mugli sir, Kulkarni sir, my own teacher and guru Ratigari sir is here, Shivanand sir is there. So I have looked up to them how they have been doing so much to IAP family, and this is just a small portion whatever I am able to do from my side. I seriously don't know how much I deserve. It's probably the chair which deserves the respect. But I'll assure you that in my capacity, whatever is possible, I'll do to the extent possible so that I'll make IIP Karnataka proud. I also thank the entire SDM Medical College, respected sir, madam. It's great honor to be along with you all here and all the esteemed IIP members of Dharwad district branch. One last 30 seconds. As a secretary, organizing secretary of Karnataka State Pedicon, which is going to come up in October, 18th to 20th of October at Mysuru, Carpedicon 2024. I extend a warm welcome from Mysuru to you all. Please, we will be very happy to host you all. Please be there for the wonderful academic event. Thank you so much.
Thank you, sir. I request, we request to felicitate Dr. Prashant, sir, HOD Pediatrics, GSS Medical College. I request sir to address the gathering.
Good morning, everyone. Dharwad, Hubli is my second hometown because all pediatricians, we are very close. We meet often since decades. I just want to say thanks to Dr. Vijay Kulkarni for honoring me here. Really, I didn't expect. I just wanted to come and sit with them. Thank you so much. Wish you all the best. Thank you, madam.
Thank you, sir. Now I request Dr. Abhijit Kulkarni, President IIP Dharwad District Branch, and Dr. Bahubali Ingale to present a memento to Dr. Niranjan Kumar, Vice Chancellor, SDM Medical College. I request sir to address the gathering.
Om Shri Manjunathaya Namaha, the dignitaries on the dais, of the dais, and my dear friends. I am very happy to welcome you all to this program. And usually, as I said, I don't like to speak. But thing is, whenever man is very innovative person, whenever he is challenged with a problem, he finds an answer to this. But the problem is that answer which he finds creates a bigger problem. And to solve that, you need a much bigger brain to work on that. That's what's happening to the antibiotics. But I think as a surgeon, we use knife. But it depends on how you use the knife. I can use it for the good and I can use it for the bad. The same way, the antibiotics is fantastic an equipment in the armamentarium of us, but which should be used very judicially. And probably this is one program will definitely help all of us to understand and how to use it. When I just came back and started my practice, the unit where I was working, if in elective surgery, if it's within 1 hour, we never used to use the antibiotics. But when I started working in Manipal Hospital, my senior said, don't do this. If there's an infection, they'll sue you because you're not put on antibiotics. So that's how the things are changing. But probably we have to learn from that and go ahead. And teaching is probably the most responsible work and most creative work, and I think something which all of us do every day. So probably this is another teaching program which is continuous. But one thing I want to say at this stage is, authority always cripples your freedom. I think you're able to understand. How a teacher can teach without producing an authority, so the freedom to think will not be curbed. So this, I want to stress on that because all of you are teachers, and to continue to do that. So the Buddha told, you had to be silent in 3 places. One is when you're angry. I think you should not talk. You should be silent, because you may make mistake if you talk. The second is, you should be silent when they are not listening to you, or when you are ignoring them, because there is no point in talking, because you will be wasting your energy. The third is, you should be silent when you want to listen to others. I think the time has come to listen to others, and we should be silent. Thank you very much.
Thank you, sir. I also request Dr. Abhijit Kulkarni and Dr. Bahubali to present a memento to Dr. Ratnamala Desai, Principal, SDM Medical College. Thank you, sir. I request Dr. Bahubali Ingali, Secretary, IIP Dharwad District Branch, to deliver vote of thanks.
A very good morning to one and all. On behalf of IIP Dharwad District Branch, I extend a heartfelt vote of thanks to everyone. First and foremost, I express our sincere gratitude to our esteemed Chief Guest, Dr. Niranjan Kumar, sir, for gracing this occasion with his presence. I would also like to extend our appreciation to our guest of honor, Dr. Sriranga Velu, sir, Vice President, South Zone, whose presence has added immense prestige to this event, and sir's unwavering commitment and continuous support were instrumental in resurrecting this workshop when it was on the brink of cancellation. Sir has revived it. We thank you, sir. We are honored to have with us Dr. Ratnamala Desai, Madam, Principal of SDM College, for her presence. Thank you, Madam. A special mention and thanks to Dr. S.N. Moti, President of IIP State Branch, and Dr. Seshikiran, sir, Secretary of IIP Karnataka State Bank, and Dr. Prashant, sir, HOD, JSS, for their unwavering support and encouragement. I would also like to express our gratitude to all the resources person, Sir Dr. Bhaskar Senai, sir, Dr. Sri Krishna, sir, Dr. Sandeep, sir, Dr. Vinod Rettigiri, sir, who are going to share their expertise and knowledge during the workshop and enriching our learning experience. A big thanks goes to the SDM team, particularly Dr. Vijay Kulkarni, sir, Vice Principal, HOD, and organizing chairman of this event, whose continuous support and leading from the front. Thank you, sir. I also thank to Dr. Vinod Chavan, the organizing secretary, to his meticulous coordination, which ensured a smooth execution today. My heartfelt thanks goes to all the delegates who have come across the district, PZs and the private practitioners who are going to distribute the richness of discussion today. Last but not the least, my sincere appreciation to the sponsors today, the CIPLA division, whose generous support made this workshop possible, and all the SDM technical staff, gardening staff, catering staff, and everyone who have contributed today. Pardon me if I have missed unintentionally anyone. Thank you, one and all.
Thank you, sir. Thank you, sir. As we come to the close of inaugural function, I want to extend my heartfelt gratitude to all of you for your active participation and enthusiasm. As you move forward into the training session, remember that this impact of program extends beyond the room. Together, we can drive change and make the lasting impact on the future healthcare. Let's start the training after a short tea break.
ಪ್ರಿನ್ಸಿಪಲ್ ಮ್ಯಾಮ್ ಆಮೇಲೆ ನೋಟಿಸ್ ಬರ್ದಿಟ್ಟು ಕೊಡ್ಬೇಕು ಇಷ್ಟು.
पाने की कोशिश की है कि हर जर्रे ने मुझे तुमसे मिलाने की इतनी शिद्दत से मैंने तुम्हें पाने की कोशिश की है कि हर जर्रे ने मुझे तुमसे मिलाने की साजिश की है। इतनी शिद्दत से मैंने तुम्हें पाने की कोशिश की है, इतनी शिद्दत से मैंने तुम्हें पाने की कोशिश की है कि हर जर्रे ने मुझे तुमसे मिलाने की साजिश की है।
आधा चम्मच चीनी, 1 चम्मच दूध, थोड़ी सी क्रीम।
ರೆಕಾರ್ಡಿಂಗ್ ಇಟ್ಟಿಲ್ಲ
ಏನಿಲ್ಲ ಸೋಷಿಯಲ್ ಅಜ್ಜಾರ್ದೆಲ್ಲ ತೋ
ನಾಗಲಿ ಮುಂದೆ ಸಾ
Welcome back. We shall commence our session. As Dr. Singarvelu mentioned, antibiotic resistance is the new pandemic. There is up to 10% rise in the drug resistance in the past 1 year, as virtually no new antibiotics have been developed in the last 25 years. It is of paramount importance to use the antibiotics judiciously. Now, we go ahead with our next sessions of TOT to learn about the judicious use of antibiotics. I welcome Dr. Bhaskar Shenoy, HOD Pediatrics, Manipal Hospital, to elaborate on pharmacodynamics and pharmacokinetics.
ಇಲ್ಲಿ ಇದಿಲ್ಲಲ್ಲ ಓಕೆ ಇದರಲ್ಲಿ ಮಾತ್ರನಾ ಇದರಲ್ಲಿ ಆಗಲ್ಲ ಗೊತ್ತಿಲ್ಲ ನೆಕ್ಸ್ಟ್ ಹ್ಞೂ ಹಿಟ್ಟು ತೆಗಿತೀರಾ okay. Welcome back. Let us go back to academics again. One of the important aspects of choosing an antibiotic, how to give, what is the ideal way of giving, what is the ideal antibiotic for that particular condition. To know about that, we need to know pharmacodynamics and pharmacokinetics. It may look like a simple pharmacology topic, but it is very important, especially when it comes to a clinical practice. When you do infectious disease cases, you manage in the ICUs where the things are different because they are immunocompromised. They have a lot of underlying problems and these things may change. So bear with me, it is a boring topic. I will try to make it as interesting or as understandable as possible. So pharmacokinetics and pharmacodynamics, over last 20 years only, it has been given some importance. People have started knowing the importance of understanding the PKPD principles and how do we apply these principles in the clinical practice. So we all have heard of pharmacokinetics and pharmacodynamics. Whenever you choose an antibiotic and you manage an infection, it is an interaction between host, drug and the bug. Because we need to take care of the host factors. He is a child, infant, neonate or elderly. Or does he have any underlying immunocompromised conditions? Or is he an immunocompetent person? Or is he on some medications which interferes with your drug which you give? And we need to know the drug also. The appropriate dose which is given is important. And the bug. When it comes to the microorganism, in addition to its susceptibility and other things, the MIC, we will talk about it later. The minimum inhibitory concentration is also important. So managing is not only giving antibiotic and knowing the dose, it is an interaction between all these three things, and that will decide, that is the basis of this pharmacodynamics and pharmacokinetics. So let us see what is pharmacokinetics. Pharmacokinetics is one wherein in simple words, if I can say, what does the body do to the drug? You know, when a drug is given, it is absorbed, it goes into the circulation, it goes into the target organs, it has to achieve certain concentration in the body, it gets metabolized, later it gets excreted. This you know. If you know this much, my job is made easy. A drug has to go inside any route, absorbed, distributed, metabolized, excreted. In the process, it may have effect. The effect may be a positive effect or a negative effect also sometimes. So, pharmacokinetics deals with the absorption to distribution, metabolism and excretion. The whole process containing these stages is taken care. What does the body do to the drug? Now, pharmacodynamics, what does the drug do to the body and the organism? You give the medicine, you give the antibiotic, what is the concentration that is needed? What effect that occurs? So, as I told, the effect can be a desirable effect wherein you inhibit the organism and you achieve the killing of the microorganism. That is a desirable effect. On the other hand, sometimes we may get what is called as a adverse events, adverse effects, which is undesirable, which is a part of the medication. So, a combination of these things, these principles is called as PKPD principles. So, both we have to know. So, in simple words, pharmacokinetics is the time course of the drug concentration in the body. Through that process, during that period, how much concentration occurs and the concentration occurring at the target site. Till then, it is called as PK. It is not Shah Rukh Khan's PK, it is pharmacokinetics, mind you. Let me be more clear. So, next, the effect, pharmacodynamics, the concentration effect relationship. How much concentration, what effect it has. That is concentration effect relation. That is deciding the clinical outcome, and that is called as PD. So, in simple words, PKPD is dose effect relationship. Is it clear? Only if you are clear, then I will go forward. So, we need to understand these things. So, having said that, let me take you through a case of 1-year-old child treated as urinary tract infection, diagnosed as ESBL UTI. You know what is ESBL? Yes or no? Why no sound? I cannot make it whether you are telling yes or no. Like this they are doing. So, urine culture shows a sensitivity to amikacin, meropenem and piperacillin. Now the patient says we can't stay till the course of the antibiotic, child is better, I want outpatient antibiotic therapy, that is OPAT. Yes, that is an accepted norm. Now a resident under Dr. Vijay Kulkarni, he prescribes amikacin. Will he prescribe OD or BD? If so, why? So, the prescription of OD or BD of amikacin, we need to know the pharmacodynamic and pharmacokinetic principle. Amikacin is given OD or BD? Yes, excellent. So, amikacin is given. Why? Very good. I think Dr. Vijay has already taught them. So, amikacin is already always given as a once a day. Why? We will talk in the subsequent topics. So, that somebody rightly told, it is a concentration dependent antibiotic. What is a concentration dependent? If there is a concentration dependent, there is one more which is called as a dose dependent antibiotic. So you should know these two things. One is a concentration dependent antibiotic, other is a dose dependent antibiotic. So concentration dependent antibiotic means higher the height, higher the concentration, greater is the killing. The height or the concentration maximum is more important. Look at this chart. When you administer the medicine, antibiotic, the blood level increases and it reaches the peak. That is called as Cmax, concentration maximum. It reaches the maximum concentration. After a variable period, it comes down and metabolizes, gets excreted. And this part is called as area under the curve. Area under the curve means the total body exposure to the drug. That means how much concentration of the drug is the body is exposed. That is area under the curve. Now there is one more which is called as MIC. You can see here. Minimum concentration needed for the inhibition of the microorganism. A relation between the AUC and MIC is one of the important aspects which decides the concentration dependent antibiotic effect. So, if the concentration is like this, higher the concentration, greater the killing, and it should be 10 times the MIC minimum to achieve a good antimicrobial effect. Understood? It should be 10 times above the MIC. Above that, how much ever greater, better is the killing, bacterial killing. Greater the concentration, greater the killing, better the killing. And it should be at least 10 times. Now, some antibiotics, their effect goes below the MIC for some, after some time. There are some antibiotics where the post-antibiotic effect prolongs, something like azithromycin, wherein the effect prolongs even after the cessation of that dose. That is called the post-antibiotic effect. And that determines the OD dose of azithromycin. Because even after it comes, it gives the effect for next 24 hours. So 24 hours dose is on that principle. So higher the concentration of the drug, higher the peak of drug concentration, greater is the killing. Understood? Yes. Now, it is the Cmax versus MIC ratio and AUC versus MIC ratio. The maximum concentration versus MIC and area under the curve versus MIC is more important. And drugs which act by this principle is, the classical example is aminoglycin. Before, we used to give aminoglycin at BD without knowing the PD, PKPD principles, and it is important that you give OD dose, the whole dose in one single dose infusion. Other drugs can be fluoroquinolones, metronidazole, and amphotericin belong to this group, but we don't give that in OD dose because of some other thing. Now, second case. child is diagnosed to have infective endocarditis, MSSA, methicillin sensitive Staphylococcus aureus was grown in culture. Parents want discharge with the oral antibiotic. Resident wants to discharge on cloxacillin. He convinced that injection is needed because it's a infective endocarditis. He is right. Because infective endocarditis is one condition where you cannot switch over to oral antibiotic. That's 6 weeks or whatever it is, you have to give IV. So he has told them and convinced. Then they told 3 times, 4 times coming is difficult, sir. Then this fellow compromised and told BD is enough. Easy, right? Yes or no? Yes or no? Only 2 answers. I have not asked many choices. So, no. Let us see why no. When you say yes, you should be able to say why yes. When you say no, you should be able to say why no. So, let us see. This is a time-dependent antibiotic. Beta-lactams, penicillins are time-dependent antibiotics. These belong to the group of so-called time-dependent antibiotics. What is the time-dependent antibiotic? Time-dependent antibiotic is how long the concentration remains above the MIC. You can see the arrow. To have a better bacteriological cure, to have a good antibacterial effect, this should be at least 50 to 60% of the levels. Time. You are clear what I told? So, how long it remains above the MIC is more important, and at least 50 to 60% of the times, if the antibiotic remains 40 to 50 at least, 50%, it will have a good antibacterial effect. Longer the duration that antibiotic is there, greater will be the clinging. For example, in otitis media, they did a study. What they found is that if you give the antibiotic in doses 40 to 50% of the times, about 70 to 75% cure rate is achieved. But if you increase it to 80 to 90% of the times, you can achieve even up to 100%. So, longer it is there it is higher, here it is longer. Only 2 words you remember, that's enough. Higher and longer. Is it difficult? No. Longer the duration that it is exposed above the MIC, greater is the killing effect. Understood? So, it is depending on MIC. So, more exposure, more killing. The antibiotics which belong to this group are beta-lactams, clindamycin, tetracycline, and cotrimoxazole. Even with the piperacillin tazobactam, they observed that the prescribed dose you give 6 hourly, and they compared with 4 hourly. The bacterial killing was better with 4 hourly than the 6 hourly. Though in practice we may not give, but pharmacologically speaking, the killing is better with 4 hourly than 6 hourly. It can achieve near to 100% effect. That is the beauty of a time-dependent antibiotic. You need to give more frequent doses. There you give single dose, achieve a high level. Here you give more frequent doses to see that it is there for a longer period of time. This is the gist of whatever I told. Appropriate PKPD indices for different antibiotics for the bactericidal properties. The type 1 is the concentration dependent with persistent, has little persistent effect, aminoglycosides. Here, to get a good therapeutic goal, we may have to optimize the plasma concentration. Whereas the time dependent with no persistent effect, you have to optimize the duration of it. And time dependent and dose dependent, it is the macrolides to optimize the amount, doses may be more. Now, the thing which I spoke about, the post-antibiotic effect. So, if you look at the first one, is the same which I told. Here, the maximum effect and then MIC, and the prolonged effect is because of the post-antibiotic effect. So, here in a time-dependent type of antibiotic, there is minimal post-antibiotic effect. So, we may have to give in a more frequent doses. So, when you manage infections with these antibiotics, what should be my way of dealing with these things? Whatever I told, in simple words, for a time-dependent antibiotic, you give more frequent dose and give prolonged infusion also in some cases. Whereas for a concentration-dependent antibiotic, the prescribed dose you give in a single dose of high dose, single shot of high dose. Prolonged infusion, you must have seen giving meropenem. If the MIC is below 16, if you give meropenem on prolonged infusion over 2 to 3 hours, the bacterial killing is better than giving a bolus. So what they compared is, in Japan also they did a huge study, wherein they compared the meropenem given on bolus or prolonged infusion. When they compared the bacterial killing, the outcome of the illness and improvement in terms of control of infection was much better with those who had a prolonged infusion. So, meropenem is better given on a prolonged infusion than a single push. Now, beta-lactam therapy, how do I optimize? So, if you give the conventional infusion over half an hour, so you are giving only half an hour. So, this is MIC, you can make out here. So, above only for short period, but if you give prolonged infusion, so if you give prolonged infusion, it remains above the MIC for a longer period of time. Understood? If you give in a conventional infusion of half an hour, the duration it remains above MIC is very short. Whereas if you give prolonged infusion, it remains higher level for a longer time with a better antibacterial effect. So, time above MIC, this is called as time above MIC. How long it remains above MIC, that is T above MIC, is significantly increased with the prolonged infusion. And that's what I told, it leads to increased efficacy, resistance can be overcome, and it can be effective in intermediate sensitive organisms also. For example, if you have some resistant organism and your MIC of meropenem shows around 16, then you are in a dilemma whether I should give or not. Such patients you can give in a prolonged infusion. Still, though the report shows it is little higher MIC, it can achieve a better bacterial cure, and that leads to decreased failure and emergence of resistance can be prevented. So there are some parameters I need to stress and talk again. One is the MIC, which I have already told. Minimum concentration of an antibiotic that inhibits the visible growth after overnight incubation. That word you have to put. It is after overnight incubation. That determines the relation between the drug and the physiological activity. Then there are other words called as minimum bactericidal concentration. For bactericidal, MIC can be little higher, above 4, the concentration can be either as MIC or 4 times. Whereas bacteriostatic, it should be manifold higher than the MIC. Now, there are some other definitions we need to understand. One is the volume of distribution. Second is the clearance. And the product of these is half-life. You know half-life. Half-life means the time taken by the drug to come down by 50%. Right? So what is this volume of distribution? When you give the antibiotic, it distributes in the body. But for the effective outcome of the drug, we calculate the concentration in the plasma, not in other compartments. The drug can go into plasma. It can go into extracellular compartment also. But that is not calculated. We need to know what exactly. It is a volume of distribution is a PK characteristic, PK parameter, which tells you the distribution of the drug in the whole body versus plasma. What I mean to say is, the distribution in the plasma is more important. Now let me see. A drug with a high volume of distribution. There is a drug with a low volume of distribution. Which is better? A drug with a high volume of distribution needs higher dose or lower dose? Wrong. It needs higher dose. Because drug with higher dose, higher VD, that is volume of distribution, it gets distributed not only in plasma, even in extracellular compartments. It immediately goes into extracellular compartment also. So, to achieve a good plasma level, to achieve a good concentration, we need higher dose. Whereas, a drug with low volume of distribution, it doesn't go out. It stays only in the plasma. It is enough if you give the minimum dose. So, it's the other way around than what you told. A drug with higher volume of distribution, it gets distributed in the plasma plus extracellular, and some of them are wasted. Wasted in the sense of no use. Whereas, to achieve a good concentration, you need a higher level. Okay? Then, half-life and clearance. Clearance is the ultimate excretion and how long it takes for the drug to clear from the body. And you have a formula there, volume of distribution versus clearance will give you T half, that is half-life. That half-life is calculated. That half-life is derived by these parameters, not just, we just read and tell, oh, half-life is this much, sir. But how that half-life came? How that half-life was calculated? Because of this. And then minimum concentration. As I told, C max, there is one more parameter called as C min, that is C minimum. And the area under curve. Area under curve means it is total distribution in the body. That means in that curve, whatever that shaded area, that indicates how much it is distributed in the body. Okay. Now, this is the pharmacokinetic indices, that is whatever I told. Okay. And now, you can measure the potency of the drug and the drug organism interaction by these three parameters which I have already described. So, hope it is clear. PGs, if you don't talk, no, either it is not clear or it is understood well. Which one I should take? If you say like this, only two options. It has gone above head. I have not understood anything. Second is, I have understood everything. I don't know which one to should take. Yeah, I think always PG should be in the front. This is one sad thing that PGs are going behind. So let us go to the next case. 4-month-old, fever, irritability, seizures, bulging fontanelle. Even the ward boy will tell it is a pyogenic meningitis. That clear it is. Okay, cultures sent. Now the resident wants to give ceftriaxone and vancomycin. Will you give ceftriaxone or ceftriaxone with vancomycin? Yeah, there are, if you read Nelson, what is there in Nelson? Not read. Okay, that is too much, sir. So, present recommendation is, in a serious infection like meningitis, bacterial meningitis, give ceftriaxone and vancomycin, because the amount of penicillin resistance is on the rise. Once you get the bacterial culture reports, then if it is sensitive to ceftriaxone, you stop vancomycin. But it is resistant, you are wasting 2 to 3 days time till you get the culture. In a serious infection, even a few minutes are should not be wasted. That is the reason. And you have some papers from Vellore, Dr. Balaji has published from South India, that the incidence of intermediate resistance of penicillin is increasing. Okay. Now, ceftriaxone you want to give. Why should I give? How much I give? How much you will give? Bolus or divided doses? The initial dose should be a single dose bolus. That is called as loading dose. What is loading dose? What is the advantage of loading dose? Let us see. Now, especially in a case like meningitis, sepsis, you should be very proactive. Your aim should be achieve a high bacterial level at the earliest possible time, right? So reduce the onset time therapeutic effect of the drug, a loading dose is given. To minimize that window period, loading dose is given. The aim is to achieve a desired plasma concentration as quickly as possible. Then you start giving maintenance dose. So if you look here, there are two situations I have given. This is the plasma concentration and this is time. Here I give a repeated dose. Here I give a bolus, single dose, loading dose. Look at the pharmacokinetics. When you give repeated doses, it needs at least 3 to 4 half-life to achieve the maximum concentration. Understood? When you give divided doses, you will have more time to achieve the maximum concentration. Whereas, when you give the bolus, within no time, you have achieved maximum concentration. So always in a serious infection, the initial dose should be a loading dose. Even some people give double the dose also, if permitted. So in a serious infection, it is the loading dose which is going to be helpful. The repeated dose can be given as a maintenance dose, but at least the first dose should go as a loading dose to achieve an immediate higher bacterial antibacterial effect and the above MIC concentration. So if you look at the loading dose, you can see here within no time it has increased. The time needed to reach 90% of the C average is approximately 3 to 4 half-lives. Means that much time you are wasting if you give divided doses. Now, loading dose is not affected by renal function. Suppose if the patient has renal abnormality also, you will sometimes think, oh, I cannot give so much higher dose now, but you can give. In renal function abnormalities also, you can give. So this is what I was trying to talk to you, the susceptibility and non-susceptibility of meningeal and non-meningeal isolates. We were talking about this thing, the susceptible, intermediate and resistant organisms. The susceptibility of penicillin for meningeal and non-meningeal isolates is different, mind you. So for the other infection, non-meningeal infections, you give a lower dose. For a meningeal infection, you need to give a different dose, higher dose. And because you don't know whether this is intermediate sensitive penicillin sensitivity or not resistant, that's why we add vancomycin. That's what I told. Okay. So MIC already I have told. Then there is what is called as a clinical breakpoint. Clinical breakpoint is a predefined value above which it is supposed to be resistant, below which it is supposed to be sensitive. That is given by, there are so many international bodies, CLSI and other things. UCAST, CLSI guidelines are there. They will, every year they formulate a thing that this year this bacteria has this much of MIC or something like that. Microbiologists know. But we should know that clinical breakpoint is important to know, because you compare the clinical breakpoint with the MIC. If the MIC and clinical breakpoint, if the breakpoint is, MIC is less than the breakpoint, the treatment is likely to succeed. If the MIC is less than the clinical breakpoint, the lab people will give some breakpoints, but you compare that with the MIC. You talk to your microbiologist always, then it becomes a routine exercise for you. Otherwise, it looks like something Veda, Purana and Bible. Yes. So, it should be implemented from this stage for the postgraduates. I have not seen any PGs going to microbiologists and talking to them. But, yeah, I was not seeing my, but now I am pushing them to go. Last week we had a few cholera cases and I made them go and see the motile Vibrio cholerae, because I have not seen for long. When I did PG, I have seen in Hubli, KMC. After that, I have not seen. And now I am seeing. So what I'm trying to tell is that when you have an opportunity, go interact with them. It will be registered permanently here. So if the MIC is less than breakpoint, your treatment is going to be successful. If the MIC is more than the breakpoint, your MIC is going to be, treatment is likely to fail. And there is what is called as the intermediate susceptibility, which depends on the lab to lab. Now I was talking about the renal failure. What adjustments should I do in the renal failure about the drug dose? One important point you should remember is that the initial dose of antibiotic related to VD and not elimination. That's why we should not change the first dose in the renal failure. After that, once you get other parameters, then depending on that you can change. But first dose should be given as it is. Subsequent doses can be changed or modified according to your other reports. For concentration dependent antibiotics, you prolong the interval between the doses, but do not decrease the doses, like aminoglycoside and quinolines. For time dependent antibiotic, decrease the dose, maintain the same dosing, for example, beta-lactam, meropenem, etc. And I spoke about persistent effect. There are some antibiotics which causes persistent suppression of the growth of microorganism even after the antibiotic exposure is ceased. And this is more with gram-positive than the gram-negative organisms. And post-antibiotic and sub-MIC effect, that also can augment. But there is what is called as a post-antibiotic leukocyte killing enhancement. There were some studies to see that even after that, the leukocidal effect was seen for a variable period of time depending on the antibiotic, depending on the host factor. So, longest post-antibiotic effect with the antibiotic which exhibits will be given as OD dose. The classical example is azithromycin. Next scenario. 1 year, sincere first year resident on rounds questions, sir, why topical antibiotics for most children with impetigo, even if you have detected MRSA? He is right, isn't it? Sampath, no? First year resident. Yeah. He was so intelligent and he started asking a question. Sir, why it is that you are telling it is MRSA and you are not allowing him to give even oral antibiotic also? You say it is topical is enough. Why, sir? Why this Kolavaridi? He asked once. Then let us see the reason. The reason is you should know what is called as a target attainment. For a PG or anybody, you have a target. For some time, just passing is a target. For some people, getting university rank is a target. For some people, going to resort for 1 week and relaxing is the target in a month. So each one will have a target. And for somebody, seeing 2000 patients in a month is a target. Then what is the antibiotic target? Let us see. If it is a non-life threatening condition, you can relax. You can achieve only 70 to 80% target. If you achieve, that's enough. Whereas those conditions which have end organ damage, something like a pyelonephritis, 80 to 90% target is needed. Whereas life-threatening infections like meningitis, septicemia, you should aim at 100%, like that fellow who wants to achieve university topper. That is for severe infections. Life-threatening infection, you cannot waste time. You cannot take chances. You have to push antibiotic. Later when the child stabilizes and you get the reports, you try to reduce or de-escalate or whatever you want to do. But initial action should be very aggressive action. That is in the 3. Okay. So to conclude, and before that, in that cloxacillin, I didn't answer. That is because it's a non-life threatening. So you give MSSA, oral antibiotic will be sufficient. Even if 2 furuncles remain, what it matters? You change the antibiotic later. Whereas in meningitis, you can't do that. That is the difference. That's why it is only minimum antibiotic given for those conditions. So to conclude, pharmacodynamic is studying the action of the drug on the organism, whereas pharmacokinetics is effect of the organism has on the drug, effect of the organism on the drug. So based on these principles, there are three categories they have classified. One is a concentration dependent with persistent effect, and time dependent with the no persistent effect, and time dependent with the persistent effect. The principles, the examples we have already described. Loading dose concept has to be practiced in severe life-threatening infections. It is imperative to know PK/PD of new molecule. Just because somebody comes and details in your practice, you don't go by that. You try to study the PK/PD from now onwards. It is important that at least some time we give to knowing the PK/PD, reading the PK/PD, and especially the postgraduate, if you start practicing from now, looking at that aspect, you will be a much better clinician than all of us. Thank you so much.
Thank you, sir, for the educational talk. I welcome Dr. Vijay Kulkarni, HOD Pediatrics, SDM Medical College, to discuss about the basics of antimicrobial resistance.
Good morning, one and all. Yes, we'll go to the next important topic, basis of antimicrobial resistance. In fact, I should really appreciate and thank a wonderful chapter made so easy by Bhaskar sir for PK and PD. I think what he told was the initial statement that he will try and make us understand. I think you have done your job well, sir. And I think it is really a learning lesson for all of us before we start an antibiotic. Before we start, I will just start with my comment that we have a very senior pediatrician, Dr. Y.K. Amdekar sir. So whenever we were interacting with Amdekar sir, he told us one thing: your hand should tremble when you start an antibiotic. What he means that you should think twice before you start an antibiotic. So there has to be some rationale for that. So why I am telling this before this talk is because of irrational and unscrupulous use and indiscriminate use of antibiotics, we have landed up with antimicrobial resistance. And it is so scary if you go to the MICU, critical care ICUs, PICUs, NICUs, we are left with no drug options. Every day we fight out in our department. 1 week back we had a meeting. What are we dealing with? What are the new drugs? And we are getting pan-resistant organisms in our ICU. What should be the way forward? So what is it? In fact, one of the speaker today told, Moti sir told that days are gone that HIV, TB, malaria, now it is not that. Now it is multi-drug resistant, which has become the menace now. And as an estimate, it is 1.27 million in 2019 because of bacterial AMR. And MDR threatens to cause 10 million deaths annually by 2050. By that time, probably we will be landing up in MICU, SICU, all of us. And we will have no drugs left out. And sometimes I wonder the way physicians write a drug. With due respect to my physician friends, there are 4 antibiotics if you get admitted in an MICU. And you know what is the cost? Even a doctor cannot afford. Per day ICU costs around 40 to 50,000. And if you are getting admitted in Apollo and big so-called corporate hospitals, it is 80,000 to 1 lakh per day. Who is on ventilator? I am not exaggerating. And in spite of that, you are really worried what will happen. So this is the order of the day. WHO has been honestly doing some of its bits of work, and they have prioritized the bacterial species according to their classification, and they have classified that these are the priority drugs who are under surveillance and who are actually getting more and more resistance. This is the list what I have put. Priority number 1, Acinetobacter. We have a separate block in our ICU that is called as a septic block, and where we admit our Acinetobacter and Klebsiella, and it is carbapenem resistant. This is very, very true. I am getting used to those drugs which I have never known. I am using tigecycline in our NICU where less than 18 years of life it is not supposed to be used. It is an off-label drug. So it is carbapenem resistance. Pseudomonas has become carbapenem resistance. Then Enterobacteria is carbapenem resistance. Extended spectrum beta-lactamase producing, that is also becoming resistant. Then the next would be, next to critical would be priority where which is high. Enterococcus feces are vancomycin resistance. We have seeing in our ward. Staph aureus, MRSA. Vancomycin intermediate and resistance. We have started using linezolid now. We have started using clindamycin. We tried getting cloxacillin. Sometimes it was not available. Cloxacillin is available with ampicillin. Ampiclox is the brand name, and we have started using that. Helicobacter pylori, it is clarithromycin resistant. Then Salmonella, they are all ciprofloxacin resistant. All fluoroquinolones, they are resistant. Neisseria is cephalosporin resistant. Then medium is Streptococcus pneumonia, they are penicillin non-susceptible. Remember this. Haemophilus influenza, ampicillin. Ampicillin has become an obsolete drug today. Probably the only indication which I remember is listeriosis. Shigella, again it has become fluoroquinolone resistant. We will start with our case scenarios. 5-year-old boy has come with fever since 7 days. If he has come today, I will first think of dengue now today. But his vitals are normal. His tongue is coated. Per abdomen is hepatosplenomegaly. What could be the working diagnosis? Enteric fever. Excellent. So we have also lab evidence. He has neutropenia. Actually, another marker is eosinopenia. Another indirect marker is acalculous cholecystitis. That is another marker. Platelets are 2.5 lakhs. So there is no doubt in the diagnosis. It is crystal clear. Probably a typhoid fever. Yes, we have confirmed that Salmonella typhi, Thetae is the easiest organism to culture. But how many of us culture that? The yield is very high when you are culturing Salmonella typhi. Look at the antibiogram of that. What sir was telling about the MIC now. So what is it sensitive? You correlate the MIC. Correlate the MIC. It is sensitive to phosphomycin. It is sensitive to ertapenem. Is sensitive. Cefoxitin. So it is almost majority of the drugs it is resistant. Only phosphomycin it is sensitive. Gentamicin it is sensitive. Amikacin it is sensitive. So now based on this culture, see look here, ciprofloxacin it is resistant. Look the MIC here, cotrimoxazole high MIC, more resistance. What is the roadmap for enteric fever? So many drugs, right from 1930. How all the organisms have evolved, how all the drugs have evolved. See this chart, wonderful chart, right from 1930. We are in 2024. See here, so many drugs in 1930, 1935 sulfonamides, then they developed resistance, then we came with beta-lactams, then we came with 45 with aminoglycosides, then we came with tetracyclines, then we came with rifamycin. Of late 2005, what is the latest after this daptomycin? 2005, another drug was introduced, was azithromycin. Azithromycin was used for enteric fever, especially for resistant strains, not as a routine use. See, some drugs are really wonder drugs, and some drugs are called as orphan drugs. Some are orphan drugs. What are orphan drugs? They are still potent, but probably they are not marketed. We have all become market driven doctors, with due respect to all of you. Cephadroxil, cephalaxin, they are wonderful drugs. They are only available in the racks of the pharmacy. None of us use them. Overrated drugs are cefixime, which is not at all to be used above the diaphragm. Okay, so this is the roadmap of resistance what has occurred in enteric fever, thanks to IAP for vaccination drive. Of late we see very less typhoid fevers because of regular use of typhoid vaccination. How does a bug develop resistance? There are two types of resistance. One is the intrinsic resistance and the other is the acquired resistance. What is fascinating? Fascinating is intrinsic resistance. Why it is so fascinating about intrinsic resistance? Because of the simple reason how we evolve as human beings, the bacteria also evolve as bacteria. The 10th generation Salmonella is the same as the first generation Salmonella. It has evolved, it has changed. So this bacteria has developed innate resistance in the own species. In the own species, there is an advancement in the development of that bacteria. More and more virulent it is becoming in the next generation of this Salmonella. That is what it is. Intrinsic resistance. So what are the characteristics? Which all organisms have intrinsic resistance for all this? Already they have resistance to all this. Bacteria, this anaerobes what we discussed, they all have intrinsic resistance to amikacin, many beta-lactam antibiotics. All gram-positives have developed intrinsic resistance to estrionam. Enterococci have developed aminoglycosides, cephalosporin. Listeria has developed intrinsic resistance to cephalosporin. All gram-negatives to glycopeptides, lipopeptides, E. coli, macrolides doesn't work on that. Klebsiella, ampicillin is of no use. Serratia, luckily we are not seeing this much. Macrolides don't have any work. Pseudomonas, sulfonamides, ampicillin, first generation, second generation. It is only what is acting against Pseudomonas. Now we use tigecycline and all those drugs, which are where only the adult extrapolated studies we are using for our NICU. Then Stenotrophomas, Maltophilia, luckily we are not isolating here. Again, this bug has already developed intrinsic resistance to this. Then Acinetobacter, again ampicillin and glycopeptides. The source is here, where we have got this. This is from a microbiology index journal. This is a wonderful picture. This is a picture of a bacteria, how it acts, how smart it is. It is more smarter than us with just one single small structure of a cell wall. And how smart it is trying to block at all the levels the various actions of the pharmacodynamics and the pharmacokinetics of these drugs. See how it is acting. There is something called as an efflux pump. So what this bacteria does, all unwanted material which has gone inside, what this drug has gone inside, it sucks it out and puts it out. There is something called as efflux pump. Because of this action, the bacteria dominates over fluoroquinolones, aminoglycosides, tetracyclines, beta-lactams, macrolides. So these drugs becomes inactive because of this efflux pump. Some bacteria have something called as block penetration. They are so smart, you see. Because of this action, the beta-lactams are inactive. The tetracyclines are inactive. Some bacteria are still more advanced. What they do? They target the modification of these molecules so that the target delivery or the end organ is not getting benefited. And inactivation of the enzymes where you have beta-lactams, aminoglycosides, macrolides. So this is how a bacteria tries to preserve its identity by using all these mechanisms and rendering these pharmacokinetics and pharmacodynamics ineffective. This is a wonderful diagram. Now again, going to the case scenario, fever, a child has come in 3 days, crying on micturition, very straightforward diagnosis, no localizing signs, child is febrile. Urine culture, yes, the gold standard of diagnosing UTI is not the urine for pus cells, but a urine culture, 10 raised to 5 colony count. This is very, very important. This all has to be read in one go. 10 raised to 5, if it is less than that, then it is not a valid urine culture. And another point I would like to stress is, it should be a clean catch, midstream urine catch. Okay? Nowadays, there is another school of thought where somebody tells that bacteriuria is a continuous process. You need not collect the urine of the first pass what the child pass in the morning. They tell bacteriuria is 24 hours. But nevertheless, the urine has to be caught by cleaning the genitalia of a child with a soap, toilet soap. Then the midstream urine has to be sent as early as possible, preferably within 1 hour to the lab. The culture is, urine culture is E. coli. So organism is E. coli, the colony count is 10 raised to 5, see here. Now it is sensitive. It is sensitive to piperacillin tazobactam, ceftriaxone it is resistant, cefepime it is resistant. Higher the MIC, more is the higher chances of becoming resistant organism. Meropenem it is sensitive. So if we go the trajectory of this antibiotics, how we have developed this antibiotics. Initially ampicillin, amoxicillin were very sensitive to gram-negative rods, then they became resistant to that. Then was the evolution of third generation cephalosporins, then came beta-lactamase, then ESBL extended spectrum beta-lactamase, then piperacillin tazobactam, carbapenems became ineffective, then carbapenem became ineffective, then finally the carbapenemase, then colistin and tigecycline. This is because of colistin. Now we are talking of colistin resistance. So much of colistin we use in our NICU today. I was never taught about colistin when we were doing MD and all. Now the only drug which is sensitive to the baby in our NICU is a colistin. So ESBL, what a word about ESBL, enzymes that break down antibiotics, penicillin and cephalosporin render them ineffective, and this gene is transmitted horizontally by the plasmids. So carbapenem resistant shows resistance. What is carbapenem resistant? How do you define it? It is at least resistance to at least one of the carbapenems, then we call it as carbapenem. Then ICMR, as per ICMR, 28% of E. coli are already resistant to imipenem. 55% of them are Klebsiella pneumonia. They are already resistant to meropenem, imipenem. Then 80% Acinetobacter, they are resistant to that. So 4-year-old boy, fever, this is an interesting child. fever with 5 days, swelling over right thigh 4 days. He was febrile, he had signs of tachycardia, he had pallor as well. He had local erythema, tenderness, there was rise of temperature when we did a systemic examination. Can somebody tell me the differential diagnosis? Very common scenario. Huh? Abscess, anything else? Swelling over right thigh. What it could be? It could be cellulitis. But what is if he had only pus, abscess, but why he should have tachycardia and pallor? That has added to that. Means that this organism is not localized, it has gone systemic. He has already developed systemic signs. He has already become pale. He is already having signs of tachycardia. Plus, along with that, there is erythema and tenderness. It is just not a localized abscess. It is something beyond that. So, systemic examination appears to be normal. Blood culture and pus culture was sent. Started on amoxiclav. Is it all right? Is it proper or no? Yes? Okay, child developed shortness of breath, tachypnea, hypotension. We used to see this. We used to see this in our ward. Chest X-ray suggestive of cardiomegaly, and along with it, this child who has come with an abscess here, this has gone a systemic infection. He is already having signs of, there is a 2D echo there, there is an echogenic mass there. So what it could be? It could be a staph aureus infection. It could be a rapidly spreading staphylococcal infection. Got it? And look at the report here. What is oxacillin resistant? Equal to or more. Again, we are dealing with something called as methicillin resistant staph aureus. So how this concept of MRSA develops? Because there is an acquisition of penicillin binding protein with significantly lower affinity for beta lactams, and how they have evolved. This protein binding protein 2 is encoded by this MEC gene, which is carried on a mobile genetic element. So this resistance allows cell wall biosynthesis to continue even in the presence of inhibitory concentrations of antibiotics. In spite of attaining the MICs, still there is, this drug is not acting, means that you are adding to a resistant strain of MRSA. So what way, this is very important slide. I think you should take a snapshot of this. All of you should practice this in the ward. Propagate and practice the culture of culturing. This is very important, especially when you are dealing with a high density ICUs. Avoid cultures like rectal swab, womb swab cultures. Distinguish colonizers from true pathogens and not treat them. They are useful bacteria for us. Collect, store and transport all samples for culture, urine, blood, etc. properly. Why this? Because this could be a programmatic error. See, overnight the duty has been busy. He has stopped to send the requisite sample to the lab. Sometimes the samples which are not to be refrigerated, you refrigerate. So these also can add to the growth of the organism. See, how you collect the sample, equally important is the sending the sample as early as possible to the lab. That is also equally important because this alters the course of the treatment plan. Then always have a habit of discussing with the microbiologist about MIC, sensitivity reports when in doubt. Yes, follow local antibiogram data. That's what we were planning. We have lot of issues in our NICU regarding the bugs. We are having some stringent policy about antibiotics. Practice escalation, de-escalation, switch therapy, principles appropriate. As enthusiastic you add an antibiotic, with the same enthusiasm you should de-escalate the antibiotic. Always the first investigation before you do the round, what you should ask is the chasing the culture. If the cultures are sterile, unnecessarily don't expose the small babies or vulnerable ones for a lot of antibiotics. Quickly stop the antibiotics. Identify in vitro, in vivo discordance, particularly in UTI. Why this is important? Because in vitro the drug may act, but in vivo it may not act. Whenever possible, use the narrowest spectrum antibiotic. This is very, very good. Don't use a Brahmastra for everything. Don't use a combination like tazobactam or a penicillin beta-lactamase with sulfonamide combination. Don't use meropenams when you are not anticipating a CNS infection. Use the antibiotics with caution. Finally, treat your patient and not the lab report alone. I think all of us can take an oath about the use of antibiotics, use it rationally and judicially. Thank you so much.
1 minute before that I will ask a question to
Yes, yes.
See, here first Dr. Kulkarni showed one antibiotic susceptibility report. Is it entry fever resistant to ceftriaxone, etc., etc. It was sensitive to amikacin and gentamicin and some other aminoglycoside. Why can't we use? Yes. See, the general practice is to look at the antibiotic sensitivity report, and whichever yes, I we withhold, R we don't use, and yes we give. Isn't it? So why can't we use those aminoglycosides? PGs. See, sir is very academic, he has given the answer, but still you have not given. See, this one, Salmonella typhi is a intracellular organism, and amikacin doesn't go into that and affect. That's all. That's why even if the sensitivity report shows that it is sensitive to amikacin and other aminoglycoside, we should not use. Because I have seen people using amikacin just because the culture report says so. It is not always. Okay. Oh.
Thank you, sirs. I request Dr. Bhaskar Shenoy to talk about beta-lactam antibiotics.
Back again. So, I'll take you through the beta-lactamase very briefly. Okay. Beta-lactam is one of the antibiotics which is used in the present practice right and left. And if you look at the global expenditure of this particular molecule, you will be shell-shocked. Other day I was just going through how much millions of tons of this antibiotic has been used across the globe. That is the irony of that. So let us talk briefly. It is a sensitization session for beta-lactamase. We will know the classification and types and uses, the beta-lactamase inhibitors and BL-BLI combinations. Now a question for you. In a bacterial respiratory tract infection, what is the antibiotic of choice? I will give 4. Amoxicillin, amoxiclav, azithromycin, cefuroxime. Amoxicillin. Okay. Very good. So, some cases we can use amoxiclav, which cases we will tell you later, but amoxicillin is the first line of antibiotic. Azithromycin and cefuroxime we should not use for routine respiratory tract infection unless there is a pressing evidence that there is an indication that it could be what is called as atypical organisms or so. Otherwise, no. Okay. Now, the mechanism of amoxicillin, it is a bactericidal drug. It acts by inhibiting the cell wall, and there are what is called as a penicillin binding sites. It binds to the cells, the penicillin binding cells, and then it inactivates. The antimicrobial resistance of these drugs is by the way of producing beta-lactamase, because beta-lactam antibiotics have their basic ring called as beta-lactam ring, and these beta-lactamase will they produce beta-lactamase, and that will destroy the beta-lactam ring. And the amoxiclav, a combination of amoxicillin with the clavulanic acid, which can cover MSSA, we routinely, it's not the first choice for MSSA, as Dr. Vijay Kulkarni told, first choice will always be cloxacillin. And as the availability issues, if you talk to the one or two companies are manufacturing, if you talk to them and get it, it will be available. In our hospital, we have made it available. In Chennai, some of the hospitals are available. Because nobody is using, it is not lucrative for them to produce so much of cloxacillin. If nobody is using, why should we produce? That is the question. So once we start using, they will definitely make. So MSSA, the next option would be cefazolin. Then H-flu, moraxella, anaerobes, sometimes it can cover. Now there are various forms of amoxiclav combination. The one with the 200 and one with the 400 amoxicillin is generally available, and usually the ratio is 4:1. There is what is called as a extended ES formulation also, wherein the higher dose of amoxicillin and usual doses of clavulanic acid is also there. So the principle of having a high dose of amoxicillin and a usual dose of clavulanic acid, what is the basis for that? See, most of the respiratory infections, be it a otitis media, be it a lower respiratory infection or upper respiratory infection, a bacterial infection usually are caused by 3 bugs: Streptococcus pneumoniae, H. influenzae, and Moraxella catarrhalis. Streptococcus pneumoniae is more sensitive to amoxicillin, and these all bugs are sensitive to amoxicillin. Of late, the streptococci has started showing increased resistance. Because the resistance mechanism is by penicillin binding protein mechanism, if you increase the dose of amoxicillin, you can target them. You can have a killing effect. Whereas, and that Streptococcus pneumoniae doesn't produce beta-lactamase, ESBL, extended spectrum beta-lactamase. Whereas, the Moraxella catarrhalis and H-flu, H. influenza, they can produce beta-lactamase, ESBL, and for that, we need to give clavulanic acid. But what studies have found that by increasing the clavulanic acid dose, it doesn't produce any beneficial effect on the bacterial killing, except that it increases the side effects like diarrhea and other things. So we don't increase the clavulanic acid, only increase the amoxicillin dose to take care of those intermediate sensitive streptococcus, intermediate resistant streptococcus pneumoniae. That is the principle of having a ES combination with the higher amount of amoxicillin. Beta-lactam, as I told, they have a beta-lactam ring with 3 carbon and 1 nitrogen, and important members of this group is penicillin, cephalosporins, carbapenem and monobactams. Now, as I told, it is widely used, widely distributed in tissues, and they penetrate into the CSF also. But they penetrate better with when the meninges are inflamed. If you look at the side effects, I'll go briefly. Anaphylaxis can occur in 0.01% of all the treatment courses. Okay. And angioedema urticaria can occur in a small group of patients. The thing is, if the patient is sensitive to one particular group, all the members of that group can have a cross reaction. So we should not use other members in the group. And they can have cross sensitivity with the cephalosporins also, so we should not use. And if there is a penicillin hypersensitivity or anaphylaxis, we should not use that. These are the broad groups of penicillins. The natural penicillin, which is penicillin G, and the anti-staphylococcal penicillin is cloxacillin. AMPI and amoxicillin have been devised or investigated for increasing the spectrum of the coverage. Aminopenicillin and beta-lactamase inhibitor combination, especially ampicillin and sulbactam combination is there. Plain ampicillin we don't use, as he told, but the sulbactam combination can be used in some cases of crab. What is crab? Carbapenem resistant Acinetobacter baumannii, CRAB. In some cases of that we can use, otherwise no. Then we have extended spectrum penicillins containing piperacillin and ticarcillin. Piperacillin is most commonly used. Penicillin side effects, they can have minor side effects, they can have major anaphylaxis also. Sometimes they can have serious toxic effect, that is encephalopathy due to cerebral irritation, because when it is given in high doses or when it is given in renal failures. Sometimes they can have accumulation of electrolytes because they either contain sodium or potassium. When you give more doses, they can have. Then orally given antibiotics can have diarrheas. So having briefed about these basic things, case scenario, there is 1-year-old child, orbital cellulitis, was on cefixime for 3 days. Blood culture was sent because fever was high, and blood culture showed Staphylococcus organism. Now it is your duty to interpret and suggest me a proper antibiotic. So how will you interpret? Can somebody fast, because everyone is hungry and few are angry because they are hypoglycemic. So we can finish fast. So if you look at that, it is oxacillin. What has happened to oxacillin? Oxacillin is the basic. So oxacillin is sensitive. That means it is a MSSA, methicillin sensitive Staphylococcus aureus. So then which antibiotic you will use? Now it is easier for you. Which one? Cloxacillin, yes. Cloxacillin is for MSSA. We spoke about cloxacillin. I will not go into the detail how to give and all. But 50 to 100 milligram per kg. Start using cloxacillin. Talk to the company people. Make available. Start using. Definitely it will be available. In an institution it is not difficult. And we have started using cloxacillin. There is one company which produces. So like, to bad luck, they don't have plain cloxacillin IV, but oral cloxacillin is available. So they told, if you start using, we will be happy to produce even the IV form also. So penicillins, now we don't use much, of course, but they are the drug of choice where in infective endocarditis, diphtheria, and one case of diphtheria came and we had to struggle a lot to get a simple medicine like penicillin. But if you want meropenem, ertapenem, and ceftaroline, what not? Easily you can get, but not this one. That is the sad state of affairs. Gas gangrene, leptospirosis, anthrax, and all those rare infections you can get. So meningococcal infections and pneumococcal infections except meningitis. Meningitis you have to be very cautious. Now, penicillin V, that spectrum of action is similar to benzyl penicillin, and it is usually used in streptococcal infections and prophylaxis against streptococcal infection following rheumatic fever. Penicillin G is oral, but orally it is not absorbed well. Now, the resistance of beta-lactam is, beta-lactam antibiotics, they develop resistance by the what they call is bacteria develop beta-lactamase enzyme, and that enzyme destroys the beta-lactam ring and makes that ineffective. That's the way it, and it also has other alternative mechanisms like target cell wall binding protein it will alter, and then the permeability changes, and that cell, it leads to cell lysis because the permeability, the water either flows in or flows out, and then it dies. When you come to beta-lactam inhibitors, we have been using right and left. There are 3 commonly used well-known beta-lactam inhibitors. One is clavulanic acid, second is sulbactam, third is tazobactam. The first one is used more often, the third one used in some situation. Sulbactam here and there we do use. So we have a various combination. The particular BLI combination will be, is not that for every beta-lactam antibiotic all can be combined. They have a specific combination. For example, amoxicillin always is combined with the clavulanic acid. Ampicillin with the sulbactam, because that combination works better. They have what is called as a better effect. Cefoperazone is combined with the sulbactam, tazobactam with piperacillin, and the dosing is based on the beta-lactam, not on the BLI combination. That you should remember. When you calculate the dose, you will calculate the beta-lactam dose, not the BLI combination dose. That we have to remember. Beta-lactam inhibitors, they are active against those who produce beta-lactamase or enzymes, organisms like Staph aureus, gram-negatives, H. flu, Catarrhalis, Klebsiella, but they don't act against the beta-lactamase produced by Pseudomonas, Enterobacter, Serratia, Citrobacter. So those organisms which produces ESBL, they don't act. They act only on those organisms like H. flu, Moraxella, who produce extended spectrum beta-lactamase. And they do not penetrate into CSF. They penetrate very poorly. It cannot be used in CNS infections, remember. And most of the CNS infections, like Streptococcus pneumoniae, they don't produce the beta-lactamase. That's the other reason why we should not give. And when you have a sensitivity or a drug for the basic drug, for example, if an organism is sensitive to amoxicillin, you should have used only amoxicillin, not the amoxiclav combination. That should be the other principle in using the amoxiclav. Co-amoxiclav is used in some conditions typically, and especially in a human bite. It is a drug of choice. Animal bite and human bite, it is the drug of choice. I don't know human bite, but animal bites we can. And schools we can see the boy, the neighboring boy who was aggressive, bit my son, and they come. If it is clear cut small wound, leave it, but it is infected wound, we have to give amoxiclav. Suppurative infections of orofacial and parapharyngeal, dental, and some urinary tract infections, not all, but urinary tract infection, if the organism is sensitive, you can use it. It is used as a second line in otitis media when there are certain indications where you have given amoxicillin and it has not worked, or you have given an antibiotic in the preceding 30 days, or there are the culture shows that it is not sensitive. Those situations only you have to use, and some cases of LRTI. So co-amoxicillin, amoxiclav more in above the diaphragm, and for infection below the diaphragm, if you are using, you may have to combine with the metronidazole to cover the anaerobes. Okay. And one more important thing is, when you reconstitute, you should advise the patient to keep it in a cool place. That 50% of the patients who come to me, when I ask, they have not been advised. Either keep in refrigerator. If they don't have refrigerator, keep in a container with the cool water, and it should not fall into direct sunlight because it will destroy the molecule. So these precautions, if you tell, otherwise they will tell amoxiclav given, but still the patient has not improved because it has not worked properly. So having said that, let me take you through the case. 2-year-old, I have 2 cases. Listen carefully. I have 2 cases. The first child is very sick, septic shock in the PICU. He is on oxygen and support. Blood culture give gram-negative bacilli. The other child is in the ward. His urine culture is negative. He is stable. His blood culture also grew gram-negative bacilli. Correct? Both are, but the scenarios are different. So which antibiotic? The culture report came Klebsiella pneumoniae in both cases. So which antibiotic you will use for A, which antibiotic you will use for B? PGs. Because now hypoglycemia set in, most of them have started dosing. So let me keep them awake. For A what, B what? Fast. Why oral? It is a Klebsiella pneumoniae. No, I will ask you molecule, not the root. Which molecule you will give? When you say IV, it is a broad thing. So it is a ESBL. The Klebsiella pneumoniae is a ESBL producer. If you look at what is ESBL producer? Very good. I think, as you told, microbiology classes have been successful. So ESBL is one where it is resistant to penicillins, cephalosporin, and monobactam, like aztreonam. So these 3 groups are resistant. So if you look at here, penicillin is resistant, then ceftriaxone is resistant. I don't think aztreonam is there. Okay. So this is ESBL. So in a ESBL of Klebsiella pneumoniae, you have 2 choices in common practice. One is meropenem, one is piperazillin with the tazobactam. Which one you use for A, which one you use for B? Yeah, A, because he is a sick child, you have to use meropenem. And the other one, you cannot give him meropenem, you have to use piperazillin tazobactam. So sick child, give meropenem. The other child has a carbapenem sparing, you have to look at. So just because it's okay, you give meropenem, not like that. Either it is really needed, you decide and then give. Then piperazine tazobactam is one of the other commonly used antibiotic in the hospitals. Few of them in febrile neutropenias they use, and infection due to Pseudomonas and Proteus, etc. Now, there is one more child, 4 days fever, sick child in PICU, and a blood culture showed E. coli, carbapenem resistant. So it is carbapenem resistant E. coli. Already on meropenem and polymyxin, because they listened to that previous class and they started meropenem, but still it didn't improve. So what will you do? What antibiotic will do? What action you will take? If you have a facility, you try to do a genetic testing. Expert Carba R. Have you heard of Expert Carba R? You have to implement that. Expert Carba R is the genetic mutation of these things are found out. Which enzyme it is defective, and accordingly you give antibiotics. Something like antibiotic sensitivity, you get the report and accordingly you give antibiotic. Here also you can find out which defect, accordingly you give antibiotic. It is not very expensive. In our hospital, being a tertiary care hospital, it costs around 2,500 or so. Maybe in a bigger other institution, cost can come down much lesser. But definitely in such cases, it is going to be helpful. We have already published one paper in the European Medical Journal, and the pattern of genetic defects we have found, and then we have published that. The only drawback of this test is, like whatever is fed into that, only those defects are seen. For example, if there are 50 defects, any one of the 50 it won't detect. Whichever you pre-feed, only those 5 or 6 defect will be seen. But it is good, because whatever common in our environment, that we will feed and we get it. So here we did that test and Carba was positive. OXA48 was the enzyme. So now the answer is, if you have a facility for that, you can give either colistin, tigecycline, which sir was mentioning, and prolonged meropenem infusion if the MIC is less than 16. But if the facility is there, and if you are able to find out that it is OXA48, then you can give ceftazidime and avibactam, which becomes more targeted therapy for these infections. The patient outcome and recovery is much better. I am not telling you to use a ceftazidime avibactam for every child with the CRE. No. It may not work also unless you document the genetic defect. You document the genetic defect. If you are able to do that, you give that. There are other VIM, then there is a New Delhi metallobeta lactamase, that is NDM. So there are many other defects. So you can use the targeted antibiotic for these severe infections. So there are irrational combinations: ceftazidime with the tazobactam, cefoperazone with the tazobactam, cefepime with the tazobactam. All those things are irrational antibiotics. So these are BLBI combinations, which I already told. This is a gist of that. And the combination of ceftazidime and avibactam, it is kept as a reserve drug in ICU infection, difficult to treat infection, where you are able to find out the genetic defect. Thank you so much.
Thank you, sir, for the informative talk. I welcome Dr. Vinod Rattigiri, HOD Pediatrics, KIMS Hubli, to share his knowledge on cephalosporins.
Good afternoon to everybody. At the outset, I thank the Central IIP, our President, Dr. Basavaraj sir, and Vice President, Dr. Singarvelu sir, and the State President, Dr. S.N. Moti sir, and his team for giving me an opportunity to talk on this dais. Especially, I really thanks the local organizer, Vijay Kulkarni, and Vinod Chavan and his team. So, let's move to quickly. Now, I think basic parts of antibiotics has been very well covered in the morning session, right from the beginning. Dr. Krishna has covered very well, and then Singarvelu sir, and lastly by Bhaskar Sinha sir regarding PKPD. That's the basic aspect of antibiotics. And now we are moving to each group of antibiotics. The one which already dealt very commonly used in pediatric practice, that is by Dr. Bhaskar Sinha sir on beta-lactam. The next one, I think the young generation now, you may not be aware of this one. When we were postgraduates, these are the drugs of is being used by every practitioner right and left. Now the days have gone, it has been moved up, so all youngsters are using the new therapies nowadays. But this is drugs which is being still used in outside practice. So let's revise these cephalosporin groups, how they are useful and where they are not at all useful. Those groups we will discuss. We'll just revise quickly on these cephalosporin groups. Now, as I said earlier, we used to be the drug which is being used in outpatient department was cephalosporin group. Before we are using amoxicillin group. So that was the drug which was being used extensively, and it was available during that time extensively. Every company was producing cephalosporin group. Now it has been come down drastically because of usage has been less in this one. But now it is time for us to realize where in pediatrics we can use these groups. What are these cephalosporin groups? How they are acting? What are their adverse effects? And more importantly, where we should not use that one. For that, we should know where it is indicated, which organism it is covering, and where we need to act, whether it is in the OPD, whether it is in the IPD, especially these cephalosporin, whether they are need to be used in the intensive care units. Now, this is the old picture. I think all senior people used to tell this was, because every fever case, and when we asked postgraduate during that time, sir, it has been already given ceftriaxone. Now, I think scenario is same, but it has been overcome. It is not the deficiency. Every fever patient means it is not having deficiency, so you need to supplement with the ceftriaxone. That is not the scenario. We need to think what is the cause for the fever and try to isolate the organism and then act based on their sensitivity, the antibiotic choice, and not every patient with the ceftriaxone. Let's begin with the again case scenario. This is a 5-year-old child with multiple skin pustules for 3 days. I think all of you postgraduates will be seeing in the OPD. So this is the common case which we are coming across with multiple skin pustules and having high grade fever. So what's your diagnosis? PGs already. Huh? One diagnosis. It is known. You are already knowing that one. Pronounce it. What is that? Impetigo. Okay. So what is the common organism causing impetigo? Staph. And one more organism is Streptococcus organism. So your diagnosis is impetigo, and how you are already knowing the organism, how you want to treat. So it is staph and cephalus. So my predecessors have spoken very well about that one. So which antibiotic you want to use for this one? Huh? Amoxicillin. Sir, you have fed with only amox and amoxiclav. No, it is. So I am an older one. The best drug still for these conditions is, and I think Moti sir agreed, still sir is prescribing this one. I think one I heard Prashant sir was telling, in Mysore, one of the old practitioners still using cotrimoxazole for every prescription. You agree, sir? So it is the trend which has been going on. Now it is not the amox or amoxiclav which you need to use for every case with impetigo, right? Though it is staphylococcus, though it is streptococcus, we have other antibiotics of choice, right? So it is the cephalexin, the first generation cephalosporin, or cipadroxil. I think Moti sir agrees that cipadroxil earlier we used to use this one commonly. The dose was 30 milligram per kg per day in 2 divided doses, or cephalexin. Cephalexin still the surgical people, pediatric surgeons are using quite often now, but of late it is going down less. But you should know, PGs, that the drug of choice for this impetigo is the cephalosporin group, either cephalexin or cipadroxil. And more importantly, it is duration, how much, that is also not 3 days, 5 days. It is 7 days course you need to complete. So that will take care of this organism. Now, having been dealt with that case, so I just wanted to know the group, how it is being divided, because over the decades, now lots of cephalosporin added into market and it is being used in our patients. So how it is being evolved over the years. So we have now 5 generations of cephalosporin group. The first generation includes, there are many others, but which are available in Indian markets. I am just spelling up those. The first one is, in the first generation, cephalexin, cipadroxil, and cefazolin. All 3 are available in the market. We should know where and how it is to be used. The second generation group is cefuroxime, cefprozil, and cefaclor. Still, it has been in use. And the third generation, which is been extensively been used earlier, and it is still continued to be there, that is cefotaxime, ceftriaxone, ceftazidime, cefoperazone. Most of these are parenteral groups, and then oral are cefixime, cefpodaxime, and ceftinir. Then these are all came because it has been used extensively, and when we noticed it has been not helping for the patient, then the next generation has come up. The 4th generation was cefepime, which is available as only parenteral dose, right? And the 5th one is the advanced group, what the Manipal group sir, Bhaskar Sena sir, are been using these things. We have not heard in the government sector, but still you as a postgraduate, you should know what are available in the market. That is ceftriaxone, cefiderocol, and ceftobiprole. These are the 5th generation cephalosporin groups. Now, my first question for all of you postgraduates is, what difference these different groups are having from 1st generation to 5th generation? First, we will know what is common to all these cephalosporins group, and then we will discuss one by one how they act and what are their where they are drug of choices. Anybody? Simple, from 1st generation to 5th generation. Huh? Very good. From? Yeah, the 1st generation, 2nd generation, 3rd generation, it is gram-positive organism mainly covering, and the 4th and 5th generation is covering the more of gram-negative organism. Very good. So that is one. Second thing is, very common is anaerobes, it is not. Right. Now, before we move on to other things, one more thing which these cephalosporins are not covering, right? So these are the lame organisms where cephalosporin doesn't act. What is this? LAME. L stands for? Yes, Listeria, atypical mycobacteria, MRSA and Enterococcus. These are the 4 organisms which are not covered by the cephalosporin. Rest of the all organisms will be covered by cephalosporin groups. Okay, so the first question which I have asked already, and you have answered that this generation, first to fifth, is starting from gram-positive organism to gram-negative organism. Okay, so another important thing is the first, second, third generation is not very well crossing the blood-brain barrier, and the fourth and fifth generation is really crossing very well. That means where it is needed for the CNS infections, we can go for the fourth and fifth generation, and for non-crossing brain barrier, we can use the first 3 generation. So this is a beautiful picture. I think it is covered very well. So it is gram positive and it is gram negative. So as we are moving towards, it is gram positive activity is coming down, whereas gram negativity is going up. Whereas these 2 groups are 4th and 5th generation, they are also mainly covering gram negative, but also covering very well the gram positive organism also. Most importantly, Pseudomonas and the MRSA are very well covered by these 2 groups. So let's move quickly to these one by one. The first generation, silent features, how they are acting. So we all know that first generation are active against the gram positive organism. So excellent activity for methicillin sensitive Staph aureus, and also group A beta hemolytic streptococcus. But they are having minimal coverage against the gram negative organism, especially for Proteus, Klebsiella and E. coli. As I said, these first to third, generally they don't cross the blood-brain barrier, so don't use it for the meningitis or even for the otitis media. And once we know that the cephalaxin first generation, cepodroxil and cepazolin, we should also know that how these can be used, which route. So cephalaxin and cepodroxil are oral route, and cepazolin can be used even parenteral also. So where especially for the surgical causes, we can use cepazolin. So this is a very good drug, both for intensive treatment as well for the surgical prophylaxis. The second generation, again more covering the gram positive organism, less for the gram negative. The second group's silent features is it also covers against, apart from gram positivity, the H. influenza, Klebsiella and E. coli, which are non-BSL producing organism, and even the non-penicillinase group like Neisseria gonorrhea, that also covered very well with the second generation group. Now the second generation group has been again divided into 2 groups, the second generation and the cephamycin group, because of slight action preferable for certain organism. This second generation has been divided into 2 groups. Okay, the cefuroxime, which is being used very well, is again like a cepazolin, is being used very well by the not the medicine people but the surgical, is having excellent activity for these organism. The third generation, again more, as I said, this is the one group which is being extensively used earlier, and now also is quite been well used. So the parenteral group, which consists of all these ceftriaxone, cefotaxime, ceftazidime and cefoperazone, we all know it is more covering the gram positive but also little bit of gram negative organism. But oral, cefixime, cefotaxime, ceftazidime, same coverage group, but the route of use of these drugs are bit different. Okay, so it is same as the first and second generation, not much difference from those groups. The fourth generation, as I said, it is only drug, which is available in the form, not in the oral form, but it is in the IV form. The biggest advantage is many of the organisms which now they are showing some resistance is very well covered by these drugs. It covers very well the Enterobacteriaceae and also Pseudomonas aeruginosa. But it is also very good in both the MSSA as well as Streptococcus pneumonia. But only thing is it acquires resistance very fast. So when we are using this drug, we should be very careful that it should not be used repeatedly for many patients together. Maybe we are in a dangerous situation where when we require for particular patient where it is to be used, during that time if you use extensively previously, it may not work for those patients. That's why this is like a reserve drug. Where it is to be used, we should discuss with our colleagues. We should have our own group in each hospital. Then we can go ahead with that one. So that the restricted use of this drug can make us better use and better purpose, and it can save our many children when it is really required. The last one, 5th generation, which is been of nowadays many ICUs where they are showing the organisms which are resistance for commonly used antibiotics. So these 3 drugs, ceftobiprole, ceftaroline and ceftolozine. So most of these are available in the market where it is being used, like in the, I think metros it is being commonly used, available. Probably I don't know, in Hubli we may not be having these drugs, especially in and around our KMC. Probably the esteemed people might be having, agree? So because these, when we are seeing these organisms which are resistant, then we can go ahead with this one. Okay. So let's again see the another case, the 5-year-old child which has come with a history of fever for 5 days and also associated vomiting, which is unrelating, and also very poor intake. And on examination, the other examination showed only spleen, the tip was palpable. So 5 days fever, vomiting, poor intake and spleen tip palpable, which is soft, is not firm. So what's your likely diagnosis? Probably, but it is too short, 5 days only fever. So you can think of other organism also, okay, not just a salmonella. But based on these clinical investigation has sent, and it was showing leukopenia, and also more importantly it has shown eosinopenia, which we again highlight. When you see a leukopenia and eosinopenia, the most likely organism is Salmonella typhi. Okay, so others, urine routine examination was normal and blood culture was sent in the institute. So based on your diagnosis, what's your antibiotic of choice? If you are admitting the child, what is your choice? If you are sending the patient on outpatient, what is your drug of choice? Quickly. 1. I think the last bench can answer for this. No? Okay, you can tell. Orally, cefixime. IV, ceftriaxone. Why? Okay. Now, why not ceftriaxone? Why only ceftriaxone? They are same group, same spectrum of activity. Very good. Any other difference? Oh, already shown. Okay. Most importantly, remember, though they are brothers and sisters, but still there is a variations in each group. So similarly, both cefotaxime and ceftriaxone are 3rd generation, but still the activity is different. The difference is one in the excretion, what you have told rightly, that ceftriaxone, it concentrates more on the biliary excretion. So where Salmonella is more concentrated, whereas cefotaxime is excreted renally. Okay, so that's the reason we use more often the ceftriaxone group than this one. The other added advantage of ceftriaxone and ceftriaxone is, ceftriaxone is used as either single or BD dose, right? So that can be, but sometimes if it is single dose or BD, we can use it instead of IV, IM also. That's the other advantage of ceftriaxone. Okay, but many times we have to be curtailed, or we should not use in those children who are less than 3 months, especially in the neonatal period. We should not use the ceftriaxone. Any reason why? Okay. Huh? Why ceftriaxone you are not using in the newborn period? In NICU you are not using, definitely, yes. Reason? One is cholestasis, right? So another, any other reason? You are using extensively in the newborn calcium containing fluid, which can precipitate if you use the ceftriaxone. That's why these are the two reasons. It will detach the bilirubin from the albumin, so that hyperbilirubinemia will be quite high if you use the ceftriaxone. Second, if you are using the calcium containing fluids, again it can precipitate. That's why in the newborn period, try to avoid. So newborn period in WHO is up to 2 months. So that's why try to avoid less than 3 months ceftriaxone. Beyond 3 months you can use. Okay. So that's the graph which we have already described. So ceftriaxone is the only cephalosporin group which does not need to have dose modified. Sir has already highlighted that which drug we should avoid in renal failure. So this is ceftriaxone is one drug you can spare. Even in the renal failure you can use full dose. Okay. So that's the advantage of this third generation cephalosporin, especially ceftriaxone group. Okay. So what about third generation cephalosporin? So already we have told about 3 IV or parenteral cephalosporin group. Other 2 are ceftazidime, which is very active against the Pseudomonas. So as an anti-Pseudomonas we can use, and along with the avibactam, sir has already highlighted for one child. So this will be much more active for the Pseudomonas. Okay. So other advantage of this ceftriaxone, it is also used for melioidosis, which is a rare disease in our setup, but we should always keep in mind that every disease is there in and around us. But only thing, we need to keep our eye open, discuss to make a diagnosis of each of these diseases. When we see that if a child routinely not responding for our routine care, we should always think of other things other than what we are routinely thinking. But this drug ceftazidime is poorly against Streptococcus pneumonia or methicillin. So we are not using. So mainly it is the Pseudomonas which is well covered by this ceftazidime. Other parenteral cephalosporin is cephalosporin. Again it is very active against the Pseudomonas, and it can be used along with the sulbactam in complicated cases of urinary tract infection. Those are the indication for cephalosporin group. So third generation oral we have already discussed, cefixime, cefodoxime and ceftidinate. So cefixime, it has been well planted in our IAP plan of action. When we see a bacillary dysentery case, the first drug to be used is cefixime. Only thing you have to make sure that you have to give a appropriate dose of this one and with a proper duration. Okay. But it has not to be used in respiratory. Remember, it's been already told there are certain drugs above diaphragm we should not use. This is the one drug which we should not use for that reason. Okay. So cefodoxime is quite good drug for respiratory tract infections. So you can use instead of cefixime for this one. So it is well covered for AOM and other pneumonia, sinusitis and pharyngitis. So that can be used for upper respiratory or lower respiratory tract infection. So having been dealt that one, as I said, the decade which we seen previous, like 1992, 2010, we have been used extensively. But still, if the usage, if you see that one, and the resistance pattern we see, still it is less, but of late we are seeing the bugs are making lot of changes in a quick response. So this is the picture what we have seen, the resistance pattern. So this is based on our ICMR, which is being published in 2022, the drug resistance patterns in India on various diseases by these organisms. Okay, so in entry fever, for ceftriaxone, we are seeing still, we are lucky that it is less than 2%. For UTI, we are seeing maximum almost 80% drug resistance. So in each of these conditions, we should also aware of this one. Where it is resistance, we can avoid. Where it is sensitive, we can go ahead with the usage of this one. In meningitis, it is 18%. In pneumonia, it is just 2%. So that means we can go ahead with pneumonia and enteric fever for cefotaxime and ceftriaxone, but not for the urinary tract infection. Okay. And now the newborn part, the cephalosporin, where we can use, where we should not. We have already highlighted the third generation cephalosporin group, where you should not use ceftriaxone. Okay. Apart from that, we should, where we should use in newborn. Can we use, or totally we can neglect cephalosporin group in newborn period? Are you using? No, not at all. Yeah, you can use still this drug in newborn period, but you should avoid in neonatal sepsis, as we are seeing a lot of resistance for this one. But it can be used as step down or what we can say step up drug when we are treating neonatal osteomyelitis, when we are discharged, because osteomyelitis takes longer duration of therapy. So first 3 weeks we give IV, and then later we are going for the oral therapy. In those situations where we are shifting it to oral therapy, we can use cephalaxin group for the newborn period. So this point you can remember. Okay, and also you can consider cephalosporin in newborn period for the uroprophylaxis, like a child having vesicoerectile reflex which has been diagnosed. When we are putting, as I said, the third generation is been well used by surgical people than the medical people, but we should be, as a medicine people, we should know in newborn period we can use cephalaxin or other cephalosporin group only as a prophylaxis therapy rather than intensive therapy in these groups. So coming back to the last part of this cephalosporin group, where what are the advantages, what are the disadvantages. So it is advantage because having less toxicity, less allergic, unlike other groups which has been described. So they are more prone for allergy we are seeing. And it is, if you see the mechanism, more of these are bactericidal group. So, and having very minimal side effects. That's the reason for the last 2 decades or almost third decade has been very well accepted, used by many practitioners across the India, and having good broad spectrum, and it is very cheap. So all these are lots of advantages for the cephalosporin group. But only thing is, as I said, especially 4th generation group, if you use extensively, we end up with the drug resistance, right? So that is the one disadvantage of this one, and as used more and more, always causing problem for each of these. So it is better for certain period we can use certain antibiotics, and we can give a gap and use that one. That will be the better option. I think Dr. Bhaskar Sena sir agree with this one, that gap, like what we are using protocol, first 6 months we use certain drugs, we can give a gap and then again use certain other group and then come back to same group, where organism will have a difficulty in identifying these drugs. So that is how we can use minimal of these drugs in a better way in our ICU as well as OPD and inpatient practice. So anywhere has it been contraindicated, cephalosporin group is only contraindicated if it is sensitive. So if there is a problem of anaphylaxis, in only those conditions has been contraindicated. Otherwise, generally it is not been contraindicated. Okay? So I think we have already highlighted about the ceftriaxone, where it is not to be used in the newborn period and why. So that is where we are now standing. To summarize, the first and second generations are mainly covering the gram-positive organism. So especially very effective in soft skin and soft tissue infection. The third generation is covering both gram-positive and gram-negative organism, but again better than the first and second generation, especially the what we have already discussed about the respiratory and the salmonella part. It is excellent in those organisms, but it is less active against the MSSA and other anaerobic activity. The fourth generation, I said, is quite good drug, but keep remembering that if you use extensively, drug resistance is quite high. And the fifth one is reserved, but we should have when it is required. So it has to be discussed and to be used the fifth generation groups. So again, revision, the most commonly used cephalosporin in outpatient, that is first generation, and then for enteric fever we are using, and especially if there is a penicillin allergy, we are going for the cephalosporin group again, and more commonly it is being used in surgical prophylaxis, the cephalosporin group. In IP, most of the drugs above diaphragm, below diaphragm, you can remember that one, use these cephalosporin group. Okay? So, and again summarizing which are oral, which are parenteral. In the first generation, cephalosporin available as parenteral group, oral is ceftazidime and cephalaxin. In the second generation, ceftazidime available as IV, remaining as oral therapy. And the third generation, which is having good groups, all are, we have already discussed, parenteral and oral therapy. Fourth, only available drug, that is cefepime, and it is available as parenteral. Fifth generation, we have only again parenteral drugs, not oral of these things. Okay? Before end my talk, again, sir has highlighted earlier, India is the only country where we are seeing all irrational combination, and all over the world, apart from India, everyone is looking at these trials of these irrational combination, whether they work or not work. Is the only country where we are using. I don't know to say whether we are good people or bad people, but it is the irrational use as far as PK and PD is concerned. So as far as possible, avoid these irrational combination. Thank you. Thank you. I think, yes, sir.
One is sir told about the fifth generation cephalosporins, ceftaroline, cefiderocol, all those things are not available in India. Even we are not able to use it. That is one thing.
Yes.
That has to be used only if the genetic testing is done and you are able to find out the NDM. For NDM, it is the drug of choice. Okay. Now, if you detect NDM, you don't have these drugs. What should I do? Will be the next question. So, the recommended therapy is ceftazidime, avibactam, and aztreonam combination. That we use. That is available. So, in a PICU, when you have such bugs and you are able to find out those defects, then you have to give that combination, ceftazidime, avibactam, and aztreonam combination. So that is about that.
Okay.
And the second thing you told, the antibiotic holiday, what you call
yes,
it.
Yes.
So that is a very well known factor, especially in enteric fever. If you look at, when we were students, we used to use ampicillin, furazolidine, cotrimoxazole, and chloramphenicol for enteric fever. Then they developed resistance. Now, when we looked back at the antibiotic sensitivity pattern, all of them have regained 100% sensitivity because we have not used them for so many years. So that is a known fact that when you give a holiday, antibiotic holiday, then they regain their sensitivity better.
Thank you, Bhaskar Sinha sir, for highlighting those important points. I think food is still on the way, so I will cover up two more because I have to go. So quickly, it is just a revision. Two more group, that is quinoline and other is cotrimoxazole. So quinoline, which we are aware, so like ciproflox, oflox, leoflox. So I will just highlight, we are not using much in pediatric use, but we should know where we are standing about these quinoline. Before understanding that one, I think this is the best case scenario we have. This is 10-year-old girl child presented with 5 days history of fever and 3 days history, child is not able to take anything. On examination, we noticed child was febrile and having very good tachycardia, and other examination showed spleen is again palpable, which is soft in nature. So again, our diagnosis is simple based on the history, it is enteric fever. Now, based on this, we sent the investigation and started on oral ciprofloxacin on OPD basis. So now question is, we have made correct diagnosis. We have started on ciprofloxacin. Now, whether it is right choice or a wrong choice. PGs, we have other drugs, sir. Why you are using ciproflox? Huh? So cipro is resistant or any other reason you don't want to use it. Okay, let's see now whether it is appropriate or wrong thing what has been prescribed. Now let's see. The first we should know how it is being classified, quinolones. The first quinolone identified in the world in 1960 was nalidixic acid. And there was a big gap in identifying the next generation of quinolone. So almost in 1990s, then we started having other quinolones. So there was a big gap between these, almost 3 to 4 decades, we don't have other quinolones. And because of this, probably nalidixic acid was developed drug resistant, and that is another biggest problem what we have witnessed. So the first generation drug was nalidix, and second was norfloxacin. It is almost 3-decade gap in identifying norfloxacin. But all of a sudden, within 2 to 3 years, we have a other large group of quinolones. That's why norfloxacin was pushed again because of certain drawbacks. It is not being used well, but we started using other quinolone groups like ciproflox and oflox and levofloxacin group. The third generation, which quickly now recently has been developed and in the market, is sparfloxacin, gatiflox and gripafloxacin. And the last one, fourth generation, is which is being available right now, moxi, gemi and travafloxacin. So these are the drugs which is being used. Now, for this thing, all these years when we were teaching for our postgraduates, and you have seen, if you have seen the older Nelson Brook also, most of these quinolones are not advised for below 8 years of age group. That was the dictum what is being written in this one. But it is being used, even though it has been written in the book, even those people who have written the books, like in US, it is being used in almost 20% of cases. Okay, so it is being used, ciproflox, even in US also and in India also. But the major concern with these was cartilage damage, which was demonstrated only in the animal, not on the humans. So because of this anxiety, the usage of these quinolones was less, especially the ciprofloxacin. But still it is being used, and of late in 2000, I think 17 or 18, I'm not sure which year, it has been FDA approved that ciproflox can be used in children more than 1 year. So till the adolescent age group you can use. So that is the dictum. Before that, it was saying that it should not be used in pediatric practice. Only concern was it can cause cartilage damage, but which was seen only in the animal experiments, not on the human beings. Okay? But if you see the usage of this one, it is being used for respiratory infection, it is being used for GI infection and other infection also. But often we are using these quinolones for the respiratory infection, and most commonly used quinolones in respiratory tract are moxi, gemi and levofloxacin. But remember, in pediatrics, the drug which is well accepted as a respiratory agent is levofloxacin. So pharmacologically is the only drug which we should use. But moxi is having lots of disadvantage in the form, side effects are quite high with that one. That's the reason we don't use in pediatric use moxifloxacin. So it has got excellent activity, but mainly for the pseudomonas, not for other. Okay? But it is being used right and left for respiratory as well as GI infections. So two diseases where it is active is one for the pseudomonas, other is for the tuberculosis. Especially moxifloxacin is quite active against the tuberculosis. All these quinolones are quite active against the tuberculosis bacilli, but quite good, often used is moxifloxacin. So this is how it is being used, and it is causing drug resistance quickly. So the various mechanism, how it is been, I think Vijay has very well explained with that graph. Same graph is being used, how these quinolones are rapidly acquiring the resistance. Even though it is being used very minimally, but it is frequently getting the resistance. So where we are using these quinolone groups? So quinolones are used only in two indications. One, multi-drug resistant pathogen without other safe or effective alternative. That means if you have other choice, you can go for other. But if you don't have choice, then you can use ciprofloxacin without any hesitation. The second indication is parenteral therapy, where it is not feasible with other effective alternative therapy. Then we can use this also as a parenteral therapy. So these are the only two indications where we can go. So coming back to our case, it's enteric fever, where we have used ciprofloxacin. So after 48 hours, we have sent the culture in the beginning, and it has shown salmonella. So this is the culture report. Look at that one. So it is sensitive to many drugs, almost all, including ciprofloxacin. But look at that one, nalidixic acid, where it is not there, na? Colistin, trimethoprim, TG-cycline, it is not been there, right? So it is sensitive to your all drugs, but they have not used the ciproflox, it is not been there, right? So what is the message from this we are getting? As I said, nalidixic acid is the first drug, and it is being used, and it is causing lot of resistance. So when we see a child where nalidixic acid is resistance, even if you use ciprofloxacin, it may not work, because it is in the same group. Though in culture it may show that it is sensitive to ciprofloxacin, but if you use that one, there is high chance that it may fail, because there is a already resistance for the nalidixic acid. So the message is here is, if a child is resistant to nalidixic acid, please don't use ciproflox, though it is easily available. It will be invariably again resistance for the ciproflox also. So another case, 8-year-old child is in ICU with polytrauma on ventilation, and he has been catheterized now. So he has developed fever with chills, and we sent a urine culture which has grown Klebsiella. So he's almost on in ICU for last 8 days, and his urine culture showed this. So it is resistance for most of the initial drugs and sensitive for the ciprofloxacin, okay, and then norfloxacin also. Now question is, can you use these as per this sensitivity report? Child is on ventilator, he has developed fresh fever, probably looks like a VAP. So can we use, based on this culture report, ciprofloxacin? It is also sensitive to norfloxacin. Can you use or we cannot? Okay, so now as we said, some holiday period we get sensitivity better. So now the reports, various reports says that it can be, even it is sensitive for these VAP associated infection. So we can go ahead and use this based on the culture report. So apart from these, where else we can use? We can use UTI caused by Pseudomonas, CSSM caused by Pseudomonas aeruginosa, and osteomyelitis caused by Pseudomonas. So that means quinolones are only used for Pseudomonas organism. Wherever it is, we can use Pseudomonas. So we are using in pediatrics especially for the cystic fibrosis and mycobacterial organism. Sorry. So in pediatrics, often now in the tertiary care centers where cystic fibrosis is common and where we are seeing drug-resistant tuberculosis, we can use these quinolone group as a therapy for these patients. So to conclude, what is the message from this is norfloxacin, though it is the second quinolone started using, but it is sidelined because of various problems like side effects and other things. So we are not supposed to use, but the pearl or importance here is when you use, it should not have a febrility. You can use in UTI norflox, but it should not be febrile. What is the meaning? Now in febrile UTI, the concentration of norfloxacin will go down. Tissue concentration is very less. That's the reason we should not use norflox as a drug for treating these UTI patients, right? But when it is not inflamed, you may have seen tissue concentration quite high. So during that time you can use, but the problem again is drug resistant. That's why in UTI earlier it has been used, now it is outdated. We are not supposed to use norfloxacin for the therapy with the, especially in the pediatric age group. Levofloxacin, we said it is the best respiratory agent we can use. It can cover many organisms when it is available. If required, we can use without any hesitancy. It can be not having much problem in terms of side effects. So you can use it as a respiratory agent. But again, the other irrational group like ofloxacin, ornidazole, which is being used extensively in adult, we don't use because we treat only with the cefixime, majority of pediatrician. But we don't use this one, but it is being used extensively in the adult age group. So it is again irrational group. So because ornidazole will displace and it can cause CNS problems. That's why you are not supposed to use this combination. Okay, so this should be avoided. Here and there, some pediatricians are using for the adolescent age group, but they should be aware that this combination is not a quite good combination. It's again an irrational combination. So it can be used as either IV or oral, and also these quinolones are available as topical agents. So we should know where we can use. Topically, we are using for conjunctivitis and otitis externa. And also for impetigo, we are using these drugs. So this is the drug dosage table for quinolones, which you are aware. Only thing again, I would like to highlight earlier, we are all depending on the West literature. So earlier, the dosage of this ciprofloxacin was maximum, like half what is being written in this table. So it was 10 milligram orally and 5 milligram IV. But now, again, in the last 3 years, in all the textbook which has been written by Western world, they have written it as the double dose. They have done their studies for their population, it is okay, acceptable. But we don't know, for our population, same is acceptable. But still, we are going with our old dose only. Whether we are right or wrong, we don't know. But we are seeing quite good results with what we are using earlier dosage. But what we would like to highlight here is we should have our own data before we accept the Western world. Till that time, okay, if you use 15 to 20 is also acceptable. If you use 10 milligram is also acceptable. So this point you need to keep when you are using these drugs. So side effect wise, ciproflox causes lots of CNS side effects, and levoflox causes more of renal damage and other things like fever, chills will be with the other cephalosporin group. Remember, cipro, CNS with psychosis more, and levo with the renal problem more. These are the common side effects we are seeing. And what hesitancy we had earlier is arthralgia and arthritis, which supposed to be, but as I said, it is more of experimental drug. Experimental animals, we have got these side effects rather than the human subjects, these things. So we can safely use these drugs for a short period of time. So summarize, in pediatrics, quinolones are having less or limited use in our practice, but we should be knowing where we need to use these drugs, especially when we have a pseudomonas. It's a drug for especially in a government sector where we are not in a position to afford for the ceftazidime or ceftazidime combination. Definitely we can use ciproflox for covering the pseudomonas organism. Thank you.
Only one small this thing. Levofloxacin you should be should not use liberally. See, the statement was in mycoplasma which is resistant to azithromycin. But you have a second choice, doxycycline. It is very difficult to prove the resistance. Why I am scared to advise levofloxacin is because we have MDR-TB, and MDR-TB, the treatment of choice, one of the drug is levofloxacin. If we start using that, we may develop, they may develop resistance to levofloxacin, then we are left with no option. So we should be very cautious in using levofloxacin. Never use unless some clear-cut guidelines which he has told. Otherwise, we should not touch levofloxacin for routine infections. Only scare is the MDR-TB.
The point here is it's less used in pediatric practice. Lesser is better. Okay, sir. Cotrigonal you can cover later.
We request all the faculty and dignitaries for a group photo.
We not only the other members also, please, we need to say all delegates along with our state president Prashant, all please. Then we break for lunch, quick lunch, please.
ಸರ್ ದುಡಿ ಹೇಳಿ ಸರ್ ಬರ್ರಿ ನೀವು ಬರ್ರಿ ಸರ್ ಅಜ್ಜು ಸರ್ ಮುಂದೆ ಬರ್ರಿ ಸರ್ ದುಡಿ ಹೇಳಿ ಸರ್ ಕೊಡ್ರಿ ಬರ್ರಿ ಇಲ್ಲಿ ಬರ್ರಿ ಸರ್ ನನ್ನ ಕಡೆ ಬರ್ರಿ ಬರ್ರಿ ಅಪ್ಲೋಡ್ ಮಾಡೋದು ದೊಡ್ಡ ಬರ್ರಿ break for lunch. We will break for lunch now.
HOD ಚೇಂಜ್ ಆದ್ರ ಅಂತ ಸರ್ ಅಲ್ಲಿ
ಪ್ರಕಾಶ ಫಾಸ್ಟಿಂಗ್ ಇದೀನಾ
Good afternoon. I welcome you all from the lunch session with a message from the IAP President.
ಎಲ್ಲರಿಗೂ ನಮಸ್ತೆ. Namaskar. Greetings from Indian Academy of Pediatrics. On behalf of 45,000 members, let me congratulate our IAP Dharwad branch led by Dr. Abhijit Kulkarni, President, Secretary Bhaubali Ingli, and Treasurer Professor I. Shivanand for organizing ABCs of antibiotic. ABCs of antibiotic, this is in a module which is very, very relevant in the clinical practice, is prepared by none other than Professor S. Balasubramaniam, Dr. Jagdish Chinnappa, and many other stalwarts like Dr. G. Sanundi and others who has been involved in preparation of this module. This is a module, it addresses a day-to-day relevant clinical practice, And today's faculty fortunate to have Professor Singaru Velu, Professor Vijay Kulkarni, Professor Vinod Ratigere. Along with that, the national coordinator of this module, Dr. Sri Krishna, who has been here to interact with all the delegates. I am sure their interaction, their delegation, which is going to be very, very useful. Our action plan module, which has module committee, which has been led by Dr. Gnanamurthy, along with Dr. Amul Pawar, who is a dynamic joint secretary, joint coordinator of this module, along with Dr. Nandish, who has been coordinating with all the branches to carry out this module. And our IAP office team, especially our South Zone Vice President, very keen to conduct this program in Dharwad, Professor Singaru Velu, who has been coordinated with all the National Executive Board members from Karnataka, Dr. Amrish Patil, Dr. Sanjeev Chetty, Dr. Adarsh, Dr. Priya Shivalli, and Dr. Venkata Chalapati, who has been coordinated with all the branches of this module to bring all the Central IAP Action Plan module. Of course, our team effort by Central IAP with the National General Secretary, Professor Yogesh Parikh, and along with the first National Treasurer, Dr. Atanu Badra, who is doing a great work at the national level with coordination with all the team members. I am sure with all this cooperation, this is the module is going to be very, very useful. Once again, very thankful to IAP Dharwad branch, especially the seniors like Dr. Srinath Mugli, Dr. Rajan Deshpande, Dr. L.S. Kulkarni, Dr. Wari, Dr. Devraj Raichur, and many of the stalwarts, Dr. Patepur, who has been involved in helping all the youngsters to take this module. Once again, I am very thankful to our IAP Dharwad team, led by Dr. Abhijit Kulkarni, Bahubali Ingle, and Dr. Professor I. Shivanand for organizing this module. Thank you very much for this. Ellarigu namaste. Namaskar. Greetings from Indian Academy of Pediatrics on behalf.
Now I welcome Dr. Prashant to discuss about Project Angel.
Good afternoon, everyone. As said, I came surprisingly to Dharwad because many of my friends, we are all here, Dharwad, Hubli. So since it was a Sunday, Moti sir was coming and Shashi Kiran, I said Sunday I'll join you. Surprisingly, my close friend Vijay Kulkarni called me on the stage and did felicitation. But it did not end there. He suddenly said, you have received the felicitation, do give and talk, at least do justice for your felicitation. So they asked me to talk on HPV vaccine. Has anyone traveled between Mysore and Bangalore New Road? Anyone of you? No. It's a beautiful highway now, just 1 hour, 10 minutes, no risk, beautiful driving, but straight road. Only problem is, it's a straight road, driving is easy, but dozing off always because no turns, no clutch, nothing. So always the driver who drives a car, he doesn't get sleep in a ghat section. Most of them, they sleep in the same road. Similarly, since morning A, B, C, D, E, F of only antibiotics is going on, we'll just deviate and see what HPV vaccine is. And this Project Angel, I think they have supported some grant to this program, and it's a must for us to talk on HPV vaccine today. I'll go through quickly. So these are the various things what I'm going to talk. See, look at the burden. Whether you take infectious diseases or non-infectious diseases, India is always colored in the dark. That is the incidence you can see. So 79,906 women die every year in India from cervical cancer. 80,000 deaths, 127,000 new cases. If we don't act, new cases will increase by 54% from 2022 to 2040. Your action today can change this picture of tomorrow for India. Life course approach to cervical cancer, you can see here 9-15 years HPV infection, then it goes on pre-cancerous stage and cancerous stage. So primary prevention, secondary prevention, and tertiary prevention is very important. In primary prevention, vaccination is always the preventive thing. So between 9 to 14 years, girls and boys will see for which brand for boys it can be given. Secondary prevention is by screening, and tertiary prevention by treating. So that's how we can bring down the death rate because of cervical cancer vaccine. So achieving elimination, 90% vaccination by 15, then 70% screening between 35 and 45 years, and 90% timely treatment. So they always says 90, 70, 90. So remember three figures: 90% vaccination up to before 15 years of age, 70% screening between 35 and 45 years women, and 90% timely treatment. Who is he? Anybody? Yeah, he is the Director General. So he has commented, Dr. Tedros, cervical cancer strikes women in the prime of life. These women are raising children, caring for their families, and contributing to the social and economic fabric of the communities, of their communities. If we don't act, deaths from cervical cancer will rise. But it does not have to be this way, so we can always prevent it. How many of you have not taken cervical cancer vaccine here? Ladies? Sure, you have all taken? If not, take today. It's worth. Now, if you have taken quadrivalent, it's okay. If you have not taken, go for 9-valent only. It's a bit costly, but still worth it. Why? Because we'll see here. Why should you focus on HPV vaccination? So physicians are the most trusted, so keep telling HPV. I'll go quickly because other speakers are also waiting. So whenever you get a chance to deal with patients by around 9 years, keep telling them this is the worth vaccine you have to take. So putting the pieces together, coming to HPV vaccine, I mean virus, you can see the theory part, which can cause cancer of the cervix, ula, vagina, penis, anus, and oropharynx. Infects both women and men alike, and estimated more than 50 to 80% will get at least one type of HPV infection in their lifetime. This is important. Then the question is why so much cancer is not there. Any HPV infection, few days, few years, it will fade away, body will fight. Only long-lasting HPV infection or carcinogenic HPV infection can cause cancer. So the body fights off most HPV infections in about 2 years, but not all. If the HPV does not go away on its own, it can cause changes in the healthy cells. Spread, all of you know, it may not be complete intercourse, it could be by touch and other things. So this is how the cell multiplies, and you can see the cancerous cell later. HPV, high-risk HPV types of HPV that can cause cancer, and persistent infections that do not clear over time. So these are the patients where either they have long-lasting HPV infection or they have carcinogenic HPV infection. They are prone for cervical cancer. 84% of cervical cancers are caused by HPV type 16 and 18. Any PGs know the brands available, how many types? Bivalent, quadrivalent. You have heard of? So bivalent we had only 16 and 18. Now quadrivalent has, what are the 16, 18 is there, 6 and 11. But 16, 18 is there in all the groups because 84% of the cervical cancers are caused by these two groups. So is my child really at risk? Okay, it's definitely very common infection. You have to convince the parents it's worth it. Prevention and elimination strategy started between 9 to 14 years old. Then 35 years old screening, 35 to 45 years, I said screening. So last tertiary care is the treatment. So first is immunize the child. Before the sexual activity starts, in India, best time is between 9 and 14 years. Then keep screening with highly identified PCRs or pap smear between 35 and 45 years. Tertiary is by treatment. On time dose, 9 to 14, 2 doses, 15 to 26, 3 doses, immunocompromised, any age, 3 doses. So important slide for the postgraduates. Cervical cancer vaccine, 9 to 14 years is only 2 doses, 0 and 6. 15 years up to 45, that is for Gardasil. Whereas the other vaccine which is there, 9-valent, it is up to 26. Just remember, after 15 years, it is 3 doses, 0 to 6. So 2 doses before 14 years completed and 3 doses after that. Very important. Why do they need HPV vaccine at this stage? Because earlier the age of inoculation, more protection, and the child will be ready with immunogenicity by the time the child gets exposed to the virus. How long will the protection from HPV vaccine last? Studies have not shown it's lifelong, but definitely long results have been shown, and right now there are no boosters required. If anybody asks 10 years back I have taken, do I need to take one more? No need. No boosters, 3 doses or 2 doses depending upon the age. Facts about HPV vaccine is the recombinant L1 capsid proteins that form virus-like particles. They are non-oncogenic and non-infectious, produce higher levels of neutralizing antibody than natural infection. So they are very safe and high immunogenicity is produced. This slide is also important for you postgraduates. You can see here there bivalent 16 and 18, quadrivalent 6, 11, 16, 18. We have 9-valent now. So apart from these 4, 5 more they have added. See here, about 15% of cervical cancers in India are because of these 5 serotypes. If someone is affordable, if they say, how is the protection with quadrivalent and this, yes. Cost, anybody knows? Anyone? 10,850, Gardasil 9, and Gardasil is 4,000 rupees. So by adding another 5, it is 10,850. What I'm saying is MRP. So if they are affordable, tell them, yes, 84% is because of these two, but there are 15% others are there. So let them have the best. If they say that is too costly, at least give them because maximum coverage is there. It's very safe, effective, it should start at the age of 9 years, and your recommendation matters. It always depends on how the doctor puts the words across to the parents. And there is a lobby, anti-vaccine lobby also. They all feel no vaccine should, natural infection should come. We should tell, first visit, you have to take more time with your parents to convince them that these vaccines are important. Second visit onwards, it goes on. It's effective, it's safe. I'll just quickly go through the slides. These are the various studies showing 2 groups and 3 groups. All have shown very good titers. Does HPV vaccination work? Yes, HPV vaccination works very well. Studies have proven that vaccines are effective at preventing cervical and other HPV vaccine. HPV vaccination can prevent most of the cervical cancers. It is safe. So more than 160 studies all over the globe they have shown. Side effects are very less. Again, this is important, this slide for you, postgraduates. These are the brand name. We had Cervarix by GSK, it's not available. That was a bivalent vaccine. Now we have Cervarix from Serum Institute. It's approved for both boys and girls. This vaccine is approved both for boys and girls, but between 9 and 26 years. But dosage is the same, 9 to 14 years, 2 doses, 15 years onwards, is 3026, 3 doses. So this Cervarix can be given for both boys and girls between 9 and 26 years. Gardasil 4, it's only for girls between 9 and 45 years. Gardasil 9, girls and boys, for girls 9 to 26 years, but boys only 9 to 14 years. Why the difference between different brands depending upon the age? Anybody? Studies are not done. Probably down the line, another 10 years or 5 years, we'll change this. Between 9 to 45 years only, everything can. Still we get the studies. As on now, this is approved. So know about this. So HPV vaccination has long-term safety, I've already told. Cause side effects, absolutely, it's very safe. Only bit like any other vaccine, local induration, local erythema, mild fever can come. Otherwise, it's a safe vaccine. The commonest side effect with HPV vaccination is what? AEF5, vasovagal. So it's always advisable, a teenager girl comes, don't make a stand and give it on the deltoid. It has to be given on deltoid, no gluteal, always deltoid. So all the precaution to be taken is make the child lie down, then give the vaccine. Let the child lie down for 5 more minutes because vasovagal, they'll fall. So that is one thing you have to take care. Otherwise, it's a very safe vaccine. So reaction, minor reaction, nothing to be worried. No anaphylaxis reported so far. Harm my daughter's fertility? Definitely not. It will improve because if there is chance of cervical cancer, cancer will be prevented and fertility will be increased. No harm, but the same thing, fertility. HPV vaccination starts at age 9, I repeat. So know this again. Between 9 to 14 years, 2 doses. 15 to 26, 3 doses. Immunocompromised, any age, it is 3 doses. Even if there's an immunocompromised child, 10-year-old, you have to give 3 doses. Early age HPV vaccination, these are the effectiveness. Earlier the age, more effective is the vaccination. Benefits of vaccinating: more time for completion on time, results in a stronger immune response, increased likelihood of vaccinating prior to first HPV exposure, decreased questions about sexual activity by parents and guardians, increased vaccinations and therefore cancers prevented, shown to increase vaccination rates in healthcare systems in US, shown to be highly acceptable by health system providers and parents in US. The best time to start is 9 years. If you start saying it 9 years, by 9.5, 10 years, at least they'll take. Can she get the vaccine after marriage? Best is 9 to 14 years, but still, as they've advised, up to 26 years, up to 45 years. You can get pap smear done, even if it is stage 1 or early, you can still give the vaccine because progression will be halted. I'll just skip these things. So parents trust doctors. These are a few words by the patients. Make a proactive recommendation. That means, like you ask in the history, leading questions. Here, they may not ask, sir, 9 years, 10 years, should we give HPV? She is 9 years, show them and be proactive, then advertise. So these are the things. Cancer prevention. These are scenarios. Eliminate, again I said 90, 70, 90. Primary prevention 90, 70% secondary prevention, again 90% tertiary prevention. In summary, HPV is very common. HPV causes 6 types of cancer. HPV vaccine is safe and HPV vaccine is effective. Be a champion. Recommend the HPV vaccine to all 9 to 14-year-old girls in your practice. Thank you. Definitely. If cervical cancer, if it is genetically coming, then it's advisable. There's nowhere in the literature it has said it is genetically predisposed to all girls, all girls. No sir, all girls. Worth promoting to all the girls. Any other question? Sir? Cost, I said, sir, quadrivalent is costly, but I tell them if they are affordable, sir, we see last few years, we pediatricians, at least we were giving all the vaccines. Now government is giving free. They come in the car with the dress, all I'll tell you ladies, the classic, the way they are dressed, my wife doesn't wear that saris and this thing. But once they take out the required vaccines, sir, all governments, sir, we go there. So that is, they have, only thing is we have to convince them. And one good thing is, government is coming up with, in the national schedule, they are planning to introduce between 9 and 14 years, 2 doses of cervical cancer vaccine. If that comes, everybody will be protected. Yes. Shortly, it will be included in NIP, sir. Probably down the line, 6 months to 1 year. Sir? IM, always IM. No, it is 2 doses IM only. Only thing is they are taking, I think, Ceravac for a very less dose. I mean, very less price. Maybe 200 rupees per dose in bulk, like COVID. But they'll introduce, that's one good thing. But from pediatricians, most of the vaccines are snatched away. Still, we'll go and see. Thank you.
Thank you, sir. I would like to welcome Dr. Sandeep Kumar to give a talk about aminoglycosides, glycopeptides, and carbapenems.
Namaste, ಎಲ್ಲರಿಗೂ. So I'll be, so I think it's already late, but it's okay. But still now we are back to our ABCA. So from Sir, nice talk, sir, it was. Because sir is also from Manipal only, Prashant sir. So, then can I put this? So the next class will be going on. This already has been discussed in the PKPD and other things. So I'll be going on very quickly. I'll be going. So this class which I tell, can I show? Yeah. So this is like your in Indian cricket team. If you think so, he's like a Rahul Dravid, I will tell. Because for many years, for say, even though in and out everyone is using intramuscular this drug, including this thing also MBBS doctors also are using in whatever the dose, maybe OD for 1 day, 2 day they give, BD something dose they are giving, but still in spite of that, it has been withstood for many years. So right away we'll go with the case there. So here on we are having a 2-year-old boy with the UTI. He had pyelonephritis. After improving after 48 hours of the PIP test was given. Following PIP test, now he is planned for the discharge. No, what is the outpatient patient? Because they want to go early home, and hence can be, if at all, what are we planning to do? And hence I will go through also very quickly, because he is a table UTI now, and has been also recovered now, and is being planned for the discharge now, and he is sensitive to both the amikacin as well as the gentamicin. So what is the dose and how much will it give? So any PGs can tell. What is the dose? Is it BD or OD you are going to give, or how is the dose? OD dose. So which one you will give? Probably amikacin, okay, OD dose, and IV or IML. So first, if we see, the first one was a streptomycin. Actually, it was already put in when we discussed regarding other antibiotics for the enteric illness. But now which we see now, the main two which we are giving now, it is the gentamicin and the amikacin. And that newer one, plasmomycin, is there only in the few hospitals in the Chennai and Mumbai they are using, but not in the children now until now. So it's not being used. They are using, and tobramycin per se, it is used mainly as in the nebulizations we use often for those with bronchiectasis and cystic fibrosis. And then neomycin, of course, is available as a topical mainly we use. And sometimes in a hepatic encephalopathy, they were going like the oral neomycin, but no way it's not being used so popularly. So PKPD, I want to this thing. So this is the concentration dependent antibiotic. So what it should be, we should give it as we should give a loading dose here we have to give, and they have a prolonged post-antibiotic effect, and hence OD dose is enough here. So, and we have to give a loading dose, good dose, and followed by an OD dose is enough. But the one thing, they have a good concentration. If in the urinary concentration is very good here, and hence UTS they are preferred, whereas coming to other organs, the penetration is not so good, and hence as an combination therapy we can add on them, but as a monotherapy it is preferred only in the UTA. Same thing I'll go. So Pratamafaction, as you know, it is a gram negative, which is mainly the E. coli and the Klebsiella and other species which you have. And synergistic activity, we heard that in one of the slide that the few are the gram positive, or most of them are intrinsically, they won't act this because it won't penetrate in the cell. If the cell wall is there, intracellular, those which are intracellular, it won't go inside. But if you add something like a beta-lactam antibiotic, beta-lactams per se, it will damage the cell wall, and hence this antibiotic can go inside and act, and hence it also can be used in few of the enterococcal sets as well, but no action on anaerobe supply, and few on as a part of the second line of AKT, we are using them actually. So as you prefer, what is important is E. coli infections 100% it can be used, but when it comes to the PICU per se as a Klebsiella fusci and Pseudomonas and Acinetobacter, which is one of the important cause for a VAP there, and hence in the VAP this is not preferred at all, because as the years now we are giving the resistant bugs we are getting. So that was preferred. So it is, again I told it is OD dose here, and it is 15 to 20 mg. What I want to highlight is it should be given as infusion over 1 hour or at least half an hour. What happens most often, if there is a nurse who don't know, if a newly joined nurse or anyone is there, she may push the antibiotic like this. So gentamicin or an amikacin, if you push it, both the ear as well as the kidney, more of both are the nephrotoxic as well as the ototoxicity, both are consideration high. So very important that it should not be pushed as IV, it should be given as over 1 hour is the best thing to do. We give it the same, and also it is OD dose, is not a BD dose as such. So gentamicin we often use, especially in the neonates and all we use often, and it is our routine we use, and it is also 7 mg per kg IV. IM it can be given IV, and one more thing is the ceiling dose is important, because if you have a child who is 80 kg old, who is a 14-year-old, sometimes you may get 80 kg, there we can't give this much of it, 20 mg per kg there. The ceiling dose or the maximum dose is 1 gram only. That you have to highlight and then remember, and do not mix with beta-lactam. The important slide in the whole of this thing, what I want to tell in this group is, do not mix in the same syringe or the same infusion set. One thing, don't give it as an IV push also, and OD dose is important. Reduction, dose reduction, for example, AK, whatever it is, in a septic shock, the first dose or the loading dose, you have to give the full dose only. Don't correct the dose now. After the next dose, or after 48 hours ideally, you need to calculate as per the GFR, whatever is. So the first dose you need to give it as a loading dose only always. Yeah. Toxicity, as I told already, nephrotoxic, where the gentamicin is much more than this thing, and ototoxicity. One more thing I want to highlight is that neuromuscular blockade. PGs can tell me which are the conditions where this neuromuscular blockade can occur in a PICU child. At least 1 or 2 first. Snake bite, very good, excellent. Then OP poisoning. Remember that OP poisoning. If you want to add an antibiotic there because of pneumonia. And one more thing is, sometimes we give for then severe ARDS, when you put the child in the prone position, we will be giving the neuromuscular blockade infusion for some time. That time also we won't give this amicus, because both of them, if you give at once, they may have the neuromuscular paralysis and cause what is called as the critical illness neuropathy or the myopathy. So there is an entity for the PGs, it can come as a theory question also. Yeah. So in case there is a risk of AK, if there is already, if the child had an AK, also concomitant nephrotoxic agents and hypovolemia, and then the longer duration of therapy and the frequent dosing, hence OD dosing is preferred. So the same thing here. So therapeutic drug monitoring usually we won't do nowadays. For the vancomycin only we do. This, it is recommended if you use it for a longer time, and hearing this thing we do often if you use it for more than 2 weeks. So clinical uses of the aminoglycosides as combination I told with beta-lactams, as I told in many of the infections it can be used, as well as in few of the carbapenem resistant, also gram-negative infections, and the neonatal sepsis of course, and the listeria. Ampicillin is the drug of choice, but this also can be used. Brucellosis we use often, and as an MDR TB, and then this is the second line drug. So as a monotherapy, it in the first slide I have put is the ESBL, UTI we can use. Locally, intrathecally for the, especially if there is an EVD is placed anything, we will usually inject this, and tobramycin I already told also, as can be given as a nebulization. So next class is the glycopeptides. So what are the drugs under this category for the PGs? Only two important. Yeah. So it is vancomycin and ticoplanin are the two drugs which are the gram positive there. Yeah. One-year-old child had been admitted with a fever and the septic arthritis, and the bus and bus culture has grown. MRSA here is not an MSSA, MRSA here. So how will you manage this patient? So it is the vancomycin versus the ticoplanin. What I want to highlight is both are one thing to highlight regarding this class is they are the narrow spectrum antibiotic acting mainly on the gram positive bacteria only, and the glycopod. And for an MSSA, as it was already told, better to use an cefazolin or a ampiclox, what we already discussed, and the CLSA breakpoint and all those MICs have been already discussed. For an MIC is very less here, so MIC less than 1 to 2 if it is there, even though you have to use a good dose, you have to use, otherwise there can be a clinical failure which can be there. So bacteria is cidal activity, and hence we prefer them in an MRSA infection compared to linezolid, which will be discussed I think later. It is a bacteriostatic it is, whereas this is a bactericidal. We hence in a septic shock or anything, we prefer go to this here only. And here, if you go to the PKPT indices, here it is both the concentration as well as the time dependent. So what is the message here? You have to give a loading dose you have to give, and as well as you can't give it as OD dose here. It should be minimum 8th hourly. So vancomycin, remember that 8th to 6th hourly also we have to give as vancomycin. So that's the one which is important. And the target, this thing is 4,000 to 600. This is the ratio of that area under the curve, with a picture was already put. For the MSA ratio it is, yeah. And CNS penetration for ticoplanin is very poor, and hence if it is a pneumococcal meningitis, if you have any child, don't use ticoplanin as far as possible. Go to vancomycin only. But when you look at the nephrotoxicity and other things, vancomycin has its own disadvantages, and hence ticoplanin only is better there. But it's a meningitis, go there as such. And amikacin and vancomycin, when you give, be careful to repeat the creatinine often, because both are nephrotoxic and you can get any time the creatinine can go. So that's what the message here. So loading dose of vancomycin is, again you have to give here 20 to 30 mg per kg, infuse at a rate of 10 to 15 mg per minute. So again over half an hour to 1 hour only it will go. Ceiling dose here it is 2 grams here. Okay. Maintenance dose Q 8th hourly, as I mentioned already. Ticoplanin we often use in younger child, or if the child has a, for example, a AKA or anything issue on where the vancomycin we can't give, there we will go ahead usually. And all this Redman syndrome, ototoxicity, nephrotoxicity, you might be knowing, interstitial nephritis and then other things. Okay. Quickly, so and hence empirically in a severely ill patients are say MRSA infection is a good example here, and we can combine this for the meropenem with a vancomycin for those who was in a immunocompromised individuals, mainly in a cancer chemotherapy and other things. We often combine them. Okay. Suspected pneumococcal meningitis also, as we put in the first case, I think you can remember that almost. Okay. And the nosocomial, and also in infected endocarditis, a few of the cases. And ticoplanin we won't use so often. It is relatively rare to use this actually. And local intraventricular also we can inject this. Last in my talk is all these antibiotics are basically used in a PSU setting only. And again, this is considered as Vijay Kulkarni sir told already, it is one of the Brahmastra what we have is the carbapenems now. Okay. After vancomycin is the carbapenems. So here we have a 9-day-old neonate, term LSCS born, whose birth weight was good, but after 1 week of life, he has come with the history of abdominal distension with a poor feeding and lethargy and convulsions also for the past 2 days. Blood and urine cultures had to come, but the CSF analysis has showed a pyogenic meningitis, which is the empiric antibiotic of the choice here. So what the PGs can tell. So here, compared to the first case we had, one slide was put, you can't remember that I think, but here, see here, amikacin, okay, amikacin, as I told, in this case, as there is a high chances of a gram positive as well as a, so it is a polymicrobial can be. Amikacin can be used, but it's not a monotherapy. 100% you can add amikacin to anything, it's not that, but you can't as monotherapy. Cefotaxime and ceftriaxone both are not sensitive here. Those are two which are important here, the meropenem and the piptas. So which one you want to use here? Why? Yes, the thing which was already discussed. Sick patient with any kind of a ESBL producing anything is there means go for the meropenem or carbapenems. Don't go to piptas here. So the thing is, don't go to piptas unless it is a urosepsis or a UTI, because piptas has very good for a UTI but not for any other. So sick patient with such a thing, go to meropenem always. Yeah, meropenem is a carbapenem. It's again the beta lactam already been discussed. I want to want in contrast to the last slide. This is a time dependent antibiotic, and hence what is the incidence here? So the importance is no loading dose is not required. It is a time dependent. You have to maintain the concentration of the antibiotic over the period of the time. And it's more the sicker the patient, go for a continuous infusion. Septic shock in a PSU, when I see, most often I go for a continuous infusion we go. But only thing, remember, once you open the vial and put it in the reconstitute it, the same vial up to 8 to 12 hours they tell. After 12 hours that stability is not so good, and hence better to change. So reconstitute so that it will give a go as a continuous infusion. So here it has put that go over the 4 hours also you can give, but here it is the time dependent antibiotic. Active against, so it is a broad spectrum both the GPC and the GNB. I told already, I used the word as a Brahmastra here. Okay. And is AMC producing GNB also? Sir, I had told also Carba test to send, and the Carba test can see which is the gene involved. So AMC, if it is there, you can use this also meropenem very well. So for the NDM or anything, you can't use this. So that's the one thing. Imipenem we don't use much except for the gram positive coverage is good, but I won't use it because it's the CNS penetration, and the most important is imipenem. By the time when we start, most of the children will have a convulsion episode. It will cause so much of a convulsion, so we won't use this. Meropenem is the drug of choice for all the thing. Imipenem, if you tell, means only one article is there which will tell that acute pancreatitis in a child with a something PHO child, hemato-oncology child with a pancreatitis there, or due to chemotherapy induced and all, they have got that it's a good drug. But other than that, no other article which is tell you. Ertapenem and doripenem, we don't have any, we won't use it. One more thing I want to highlight is, have you heard of a pharopenem? Anyone can know that pharopenem? Oral, so remember that it's not an ideal carbapenem, and avoid using this single pharopenem. Most of our colleagues, who's probably adult colleagues who's they treat, they may give it to 15-year, 14-year with the UTI, because it's very convenient and good drug like that. But avoid using pharopenem because the meropenem and the carbapenem resistance may increase. So use there as the Taxim or any other oral antibiotic or any other antibiotic. So this is the message here. Yeah, usually the European, yeah. And it is also not a carbapenem also they tell. Few of them won't agree for that also is there. But it has been somewhat used. I think last IAP article has also come in the last year of the PGs can go through. Don't use it often. According to me, all the pediatricians, at least we should not use it. according. And it is available as I think 400 mg or something is available, not for the single dose at all. Should not use according to me. And then, so it's already been discussed, I told already, in an immunocompromised region, it can be used to the infection and the most important here is the de-escalation is most important. Sometimes in a septic shock, even I put on a meropenem because already when we get a referred child, the child would have already on many antibiotics. I go for meropenem only first because the shock. Once we get a culture report, if the culture doesn't stay, I de-escalate it. Go to Piptas or some other thing. BLBL I go usually. Okay, so that's the one thing. Not appropriate. So Brahmastra you can't use anywhere. Like that, all the respiratory infection also you can use just only in an immunocompromised child. Immunocompromised child is there, use this. According to me, no. So dosing, as I told, better to give it as over infusion, and a sick child, it is 40 mg per kg. So don't go for more. Many books may give also 10 mg per kg, also 20 mg per kg. I tell sick child who is in the PSU, go for 40 mg per kg. In a ward, you can option is there for that. As you use a continuous infusion also, it is good. Imipenem meropenem, often we don't use. There is the it's already been discussed already. One thing is valproate, if the child is on, be careful that it decreases the valproic acid concentration as much as 90%, and the child can have the convulsions, and hence meropenem is not preferred there. Most alarming to see that the Acinetobacter Baumani, which is for the VAP, has shown 80% resistance, and hence if you have the culture, it's better to send for the expert carba test to know the this thing. It's already been discussed already based on the expert carba. It can be used. This slide was already discussed. Sick child, go for carbapenem or meropenem you go. Don't go for the BLBL in a sick child. Why that tell is there is something called the inoculum effect of that for the tazobactam, because significant number of the if the organism load is very high until in a sick patient, that will increase the MIC concentration of antibiotic, and hence it won't act there, and hence don't go for this. So here this slide is put only to tell that this has been discussed already. Meropenem is also sensitive here. If you see the cefatoxime and the cefatoxime, they also are also sensitive, but something called as already been discussed. This also AMP-C category of the beta-lactamases. Some time there can be an in vitro and in vivo difference. In vitro the culture may show a good this thing, but in the when you go into the patient treatment, the patient may not respond. This is one of the example for that. Hence, be careful. Again, send for any test like the carbat test here. So, not only the microbiology, which is important here, you have to think also about the clinical, this thing also, patient is also important. AMP-C, it's almost already told already, Enterobacter and Klebsiella, the AMP-C. PGs, you know the Ambler classification of the beta-lactamases. Please go and read if you are not read. It can come for as a theory question also as beta-lactamases. What are the groups, what are the things, which one to use where, where it will help this carba test. So, aminoglycosides at the end, only thing, it is the gram negative and outpatient therapy as a monotherapy for UTI, and there are the nephrotoxic. Already discussed. Glycopeptides, we have the vancomycin, which is a main thing, and also ticoplanin sometimes for OPAT, but we won't use it often. And the carbapenems, as I told, it is a Brahmastra, so can't use in any in and out infection. So with this, I'll be ending this. Thank you.
Thank you, sir, for the educational talk. Now I would like to call Dr. Sri Krishna for his talk about macrolides.
I think we are coming to, I think 1 or 2 sessions more. I think Vijay sir gave us a wonderful lunch. I think I request PGs to kindly stand up. Okay, just to, a lot of questions this time. Okay, just to stand up so that your eyes become more open and you sleep little less. Okay. Sir, you are all very attentive, sir. I think. Where is the light here? So macrolides, we'll be talking about macrolides. We'll be dealing about your erythromycin, your azithromycin, clarithromycin. Are the differences real? Okay, first what we should know is the erythromycin was the first macrolide in 1952, which was discovered. Then we had semi-synthetic thing, clarithromycin, azithromycin coming. Here we'll be doing some differences between all the three. So as usual, we'll start with the case scenario. We have a 40-day-old infant, birth weight of 3.3 kg, now weighing 4 kgs, more than 10 days cough, severe bouts of cough, occasional apnea after cough, well in between bouts of cough, unimmunized child. Okay, so clear-cut diagnosis. We are dealing, and total count of 27,000, 67% lymphocytes. X-ray seems to be normal. So here we are dealing with pertussis. Okay, so what is the antibiotic of choice? Macrolide. So again we have one more case here, a 6-year-old child, fully immunized, cough, fever, leg pain, malaise, headache, tachypnea, just scattered crepitations are heard, saturation 95%. This is the X-ray. Received amoxicillin, clavulanate and linezolid. After this session, I think most of you will not do this, but this has happened. So we got a reference with such prescriptions. Okay, so what do you think? What is the diagnosis here? Yes, so this is likely bugs are your atypical pneumonia. Again, antibiotic of choice here will be, yes, so easy, azithromycin. So these are group of antibiotics of a macrolide ring, okay, with one or more deoxy sugars which are attached. Erythromycin, clarithromycin, azithromycin. 14 macrolide rings are erythromycin and clarithromycin. 15 macrolide ring is azithromycin. This you remember because this helps in our drug interaction, toxicity, this plays a role. So older one erythromycin, then we had clarithromycin, roxithromycin, azithromycin. So older ones, acid labile, narrow spectrum, GI side effect, shorter half-life. Your greater ones are broader spectrum, oral effective, longer half-life, azithromycin, 68 hours, and less toxicity. And in AWARE classification, where it comes, azithromycin? Morning we heard, you should be aware of AWARE classification. Assess, watch and reserve drugs. So this comes in watch group classification. Okay. So this is the mechanism of action, 50S ribosome, subunit, bacteriostatic activity and bactericidal activity at higher concentration. This is the pharmacokinetics of erythromycin, clarithromycin, azithromycin. Okay, so variable absorption of erythromycin. Remember the half-lives of 1.2, so the interval 6 hours, all those things for erythromycin. Clarithromycin 3 to 7 hours, azithromycin 68 hours. And we should also remember azithromycin has an important anti-inflammatory, as more anti-inflammatory and immunomodulator action too. So drug interactions. Okay, so you can see 3 figures there. We have azithromycin, clarithromycin and erythromycin. In that, one is a happy figure, okay, of the first one. You can make out here. So here the drug interactions are less with your azithromycin. What are we worried? We are worried about your severe SVTs, all those things with your drug interaction, which is more in clarithromycin and erythromycin because of the molecular structure. That you please remember. But still we have to use azithromycin with caution, IV azithromycin. So this may increase concentration of digoxin, theophylline, phenytoin and many other drugs, basically cytochrome P50 inhibitors. So these are the spectrum of activity. Atypical organisms, your Legionella, Chlamydia, Mycoplasma, drug of choice. Then gram-positive aerobes, clarithromycin more than erythro, more than azithro. Then gram-negative, your azithro more than clarithromycin, more than erythro. Salmonella typhi we use only azithromycin, not a first-line drug, second-line drug. Then your H. influenza, Moraxella, Neisseria, they do not have any activity against Enterobacteriaceae because they have a enzyme which degrade your macrolides. Then others are like Bordetella, Mycobacterium avium complex. Then the list continues. So what we should remember here is Streptococcus pneumonia, we are getting very high resistance to macrolide group of antibiotics. So be very cautious in using macrolide as the first line in your group to pharyngitis. And Salmonella typhi, only azithromycin. These are the therapeutic implication. Mycoplasma, Legionella, Chlamydia, any macrolide. Your pertussis for azithromycin you can use. Then Mycobacterium infection, non-Mycobacterium tuberculosis, Clarithromycin, azithro first line. Then Strepto staph infection, they are alternatives to patients who are allergic to penicillin. So remember, they are not for URTI, LRTS and skin and soft tissue infection. Our Rattagiri sir put a figure that fever is not a sign of ceftriaxone deficiency. Similarly, all cough do not need a macrolide or a azithromycin. So what are the therapeutic implications? With pyrimethamine, azithro has excellent penetration against toxoplasma, and spiromycin in pregnancy we can use. Single dose of azithromycin for chlamydia, non-coccal urethritis and chancroid. So little bit about three drugs, azithro, erythro and clarithrol. So they have 10 to 100 fold higher than serum. 3 to 5 days therapy is enough, except for Legionella pneumonia, where the treatment of choice is 14 days. So they have strongest activity against Mycoplasma pneumoniae. They are, as sir said, typhoid, it is a second line drug. Then scrub typhus, it can be a substitute for doxy. Then single dose in cholera. So what is the indication of azithromycin in typhoid fever? Okay, dose we have to remember, it is 20 mg per kg per day or 10 mg per kg per dose. The dose should not be suboptimal. Maximum dose we can go up to 1 gram. Okay, where it is used, therapeutic failure, XTR typhoid. Okay, and for relapse, suppose if the kid is allergic for ceftriaxone, or if the child has drug fever, maybe a ceftriaxone fever. Then coming to clarithromycin, dose is 7.5 mg per kg, twice daily for 7 to 10 days. Again, Mycobacterium avium, atypical Mycobacterium, toxo, resistant lepra, H. pylori induced peptic ulcer along with PPI and amoxicillin for 14 days. So role in non-tubercular Mycobacterium, leprae, ulcerans and Mycobacterium avium. So along with your rifabutin and ethambutol, clarithromycin daily or azithromycin weekly is useful for the prevention of disseminated Mycobacterium avium complex. So this is the comparison of erythromycin and azithromycin, 30 to 40 mg per kg per day dose. Remember the dose, diphtheria, chlamydia, all those places we use. Azithromycin doses less than 6 months 10 mg followed by 5 mg, more than 6 months, less than 6 months is 10 mg and more than 6 months 10 mg followed by 5 mg. So pertussis, it is same for treatment and this one. Other uses, chemoprophylaxis, azithro is alternative for tetracycline for leptospirosis. Then Acrobacterium pharyngitis comes and this can cause sore throat. One of the DDs, morning first slide which we showed, no? Then azithro 5 days for cat scratch disease. Then it is some as a prokinetic effect and immunomodulatory effect in your COPD and cystic fibrosis. Doses 40 to 50 mg of erythromycin, maximum 2 gram. Clarithrol 7.5 mg, maximum 500 mg. Azithro dose 10 mg per kg per dose. For enteric fever, please remember the dose of 20 mg per kg per day, maximum of 1 gram. Side effects, nausea, vomiting, headache, dizziness, abnormal LF, all those things. Remember prolonged QT interval, especially seen with your erythro and clarithrol. Then erythromycin used during infancy, especially in small babies, hyperplastic pyloric stenosis it can have. Then erythromycin estolate, a base, can cause cholestatic jaundice. So azithro, Mycoplasma pertussis first line, enteric fever second line, clarithrol, Mycoplasma non-tubercular Mycobacterium and H. pylori. So finally, before we stop, it is no or red in full red star mark. It is not used to URTI, LRTI, skin and soft tissue infection, dysentery, fever without focus, and simply for the sake of writing, don't write azithromycin. I think thank you. And one more time, thank you Vijay sir and all the Dharwad branch organizers, everybody, Kulkarni sir, everybody. So it was wonderful being here. Thank you one and all.
Thank you so much, sir, for the didactic type. Now I welcome Dr. Sandeep Kumar to talk about tetracyclines and colistin.
I think we'll go fast. Okay. Yes. I can go to slides first. Slides, yeah. These both are very short classes. I'll be getting us. I think pages should not feel that you are getting bombarded with all antibiotics, but these are vitals. Remember that the antibiotics which are there is a vital for every practitioner, including adult or whatever branch of medication or whatever branch of medicine means antibiotics is a vital. Without antibiotics, yeah. So we'll go into the next group now. The tetracyclines. We'll begin with a case there. We are PGs I want you to concentrate. I will be asking you. Yeah. We have a 3-year-old girl who has presented with a fever for 5 days, unsteadiness and some ataxia kind of thing she has, and irritable and photophobia. If you put on the light, she is not able to open the eyes. She's always sleeping, and also has pallor. Some few lymph nodes are palpable. No rash there. However, on abdominal examination, has the abdominal hepatosplenomegaly. Yeah. Any differential diagnosis or the diagnosis? Either 1 or 2, 3. Yes. So has pallor, hepatosplenomegaly, acute onset, fever for 5 days. Yes. At least one answer. Yes. And tell at least. Yes. Open your mouth. It's okay. If it is wrong also, I won't say it. It can be right in many things. Yes. I'm not getting any answers. Okay. I think there must be very good lunch, sir, it was. So I think very nice lunch. That don't sleep. Yeah. Some answers have come, no? The pallor is there. Cerebellum, excellent, sir, excellent. Very good diagnosis. Yes. Anything else? Okay. On CBC, when you did MPQBC, negative, sir. Then, as it's not CBC, neurological it is examination, bilateral, horizontal nystagmus she had, and also truncal and peripheral ataxia. CBC, when you see now, actually the anemia was there. HB was 8.7 with a WBC of 9,500. Platelet was normal. CRP was high, actually borderline high, more than 40. AST-LT were borderline, it is elevated 100%. More than 3 times. Blood culture has come already sterilized. And LP we did, and in the LP there was a lymphocytic response. However, glucose protein were normal. X-ray normal. Ultrasound again same findings. No other abscess or anything. Yeah. Now anything clue is there. Now at least any other thing you want to think? Any sort of infection? At least tell entry, whatever you know you can tell at least. MPQBC I think we have to add here. So, sir told us I think we will add it. Okay, yes. History, okay, yes. Any other infection? Okay. Next slide. Before that, usually my PG had called and told it as they are from Rani Bennur. Rickets here infection. So usually we see that no Rani Bennur and Badgi when they tell us usually either if they are from the Rani Bennur Badgi, I think this will be scrub typhus. I'll be giving without anything as an empirical doxy will add. Yes. I think the next picture should give you the evidence. It is what? A scar which is there or the tick bite mark where the ticks will go and sit on the moist and humid and the hot areas, especially in the groin or the axilla or the neck side they will go. So you can see that. So here the Wilfilix and also come good titers and IgM titers for the scrub typhus was positive, and hence IV doxycycline, which is given as 2.2 milligram per kg per dose IV BD. OD dose we won't prefer. Usually we go for the BD dose, and then also 100 mg is the maximum which you can use. You have to remember that. Okay. Had clinical improvement also. So remember that IV we can use if usually in a meningitis you can use. Don't combine both azithromycin and the doxycycline. That's the message here. So tetracycline has come they have come like a old wine in a new bottle. Like that, they have come now after a long time now. So as emergency, but the concerns were there in the last few years that whether we can use the tetracyclines group of drugs in children, because so many these were the reports were there. The one thing was the teeth enamel damage as well as for the hepatotoxicity also. Can we use them? Because even here also in a scrub, the this thing also liver enzymes are also high. Can we? But the red book now it tells that it can be very safely used up to 21 days like that. Any infections are there where the doxy has to be given really long? The PGs can tell me. For 3 months or 6 months, is there any infection? I think this is the melidiosis, if you heard of a Burkholderia species. Melidiosis also, doxycycline is one of the drug as a prophylaxis, means after the IV phase, you can give for the 3 to 6 months. So only 2 drugs are important here. It is the tetracycline and the doxycycline is the next. Both are bacteriostatic. They are. Acne also we use them most often, and the doxycycline, as I told already, has good CSF penetration also. So common indications is the rickettsia is now the drug of choice anyway, and the cholera, and as well as the leptospirosis also sometimes we use this. And as I told, it is in the Burkholderia also we can use, and the limes also we can use. This is the most of the indications. Atypical pneumonia was already put. The next class, which is one more in the, which is used often in the PICU. This is like again like a Brahmastra or what we call, is a tigecycline which has come now. It is a glycine, I think only glycine antibiotic. This is a broad spectrum again with the aerobic and anaerobic coverage both. So remember, I forgot to tell that meropenem and the tigecycline both, when we give, we need not add a metrogyl. So remember that meropenem or the TG when we give, do not add this thing only metrogyl, both because both have an anaerobic coverage we have. Both of them actually were used mainly for the intra-abdominal infections, but currently the tigecycline has come to our PICUs as well as the neonatal NICUs. They are used in the MRSA and VRE, vancomycin resistant enterococci. It's the most important here, and the penicillin and the streptococcal also, and DSBL and other things also, even for the carbapenem resistant Acinetobacter. But however, legally, if you think of that, it's not FDA approved, and even also it's not avoid. It has to be avoided. They tell the studies. We don't have much on this actually on the tigecycline hence, but in and out sometimes, as per the report, we may have to use this drug. We can't and administer only for the IV only. It is administered. Okay, minocycline we don't have experience. Usually I won't use. Here we have a 5-month-old, again the next case, who has come with a fever, cough for 20 days. X-ray, if you see, there is a paracardiac, usually the interstitial opacities, and as referred also had an episode of convulsions. Investigations revealed a normal CRP and a count. Afterwards, on admission on the second day, became drowsy. Your condition also worsened. He had this thing also, and repeat chest X-ray. It showed a patch on the right side, and the ceftriaxone we added. Next day, the condition again worsened, intubated and ventilated, changed to meropenem and the vancomycin. CRP and the counts are high. This went into a full-blown also septic shock also here. Had a pneumothorax for which the ICD was put, and the bactec or the cultures again came as a carbapenem resistant Klebsiella infection. Remember, carbapenem resistant and then meropenem has also not acted. So hence, in the carbapenem resistant, one more which we can use is the Klebsiella pneumonia in colistin, as well as this also can be tigecycline. Colistin is the empirical drug, but also TG here for the colistin there was not much of a response, and hence finally we went for the tigecycline. They went. Ball was also done. Ball we don't do often, in only in the severe cases itself. Whereas here phospho and TG both we use. Phospho will be covered in the next slides. I will not be going, for which the this child had responded and improved, and we could extubate the child. So already, so the last slide which I want to put is the colistin. So colistin is also, it's also a Brahmastra one thing, but one thing to remember, this is a narrow spectrum, mainly narrow spectrum, and it is mainly for the gram negative infections, MDR gram negative infections, MDR gram negative infections only, it is the colistin. Culture reports I want to tell, regarding the culture reports, most of the reports if you see, this antibiotic sensitivity for the colistin will not be written as yes at all. It will be written as I always. I means intermittent, because they won't do it often. The method you should ask, this is called as the broth dilution method. That broth dilution method itself should be done. If there is a microbiologist, go and discuss with the microbiologist. And whether if that broth dilution method is done, then only it is you can believe that. Otherwise, you can't believe that. Okay, so that's one too high. It is a reserved drug mainly for the VAP, Then the CNS infection, of course, it's put there. Klebsiella dosage, if you see, it comes usually in millions. It is put as a CBA. CBA means the colistin base. It is base activity, but I tell it in millions because the ampules or the vials which you see comes at millions. It is usually the ranges from usually 50,000 international unit per kg per dose it comes. So that's, and also we have to give it as a TID. In our PSU, we usually go for polymyxin B. I think the PGs must know that colistin is also called as polymyxin E. It is called as polymyxin B is the what we use often. For a usually VAP we go into polymyxin B. Why we go into polymyxin B is the only thing. The penetration is it good with the polymyxin B, and also what it is the active form of the drug. It is the active form of the drug, which is it need not get converted, and hence in a patient with a AKI or anything, the colistin may harm much more. And hence we go for the polymyxin B most often, as the nephrotoxicity is also less IVM and NB. So I'll end with this. One thing I want to tell is colistin is also available as oral medication. You might have heard this. If any practitioner is using colistin as oral, please avoid using it. Sometimes an acute GE, earlier the practitioners used to use oral colistin. It has a poor bio availability, and almost the 90% of the drug molecule will remain in the gut only. And so colistin is good for acute G, it's okay because of the gram negative, but avoid using it because whatever the 10% it may lead to this VAP kind of thing, or the colistin resistance is much more increasing. So thank you, sir, and thank you Vijay Kulkarni, sir. So he's like usually I tell sir as my godfather actually, and he comes to Manipal, he has so good care and everything, all this, even the dinner including everything will be very fine here. Thank you, sir, so much, and thank you IAP this thing Hubli Dharwad sir also for giving me an opportunity, sir. Thank you so much.
Thank you, sir, for the informative session. I now welcome Dr. Vijay Kulkarni to take a class on fosfomycin, linezolid, and clindamycin.
Thank you, Krishna. Thank you, Sandeep. I think they have to travel back to Mangalore. So thank you once again for coming as a faculty, and this is my last talk. After that, I promise you a good tea. Okay? So I know we are bombarded with a lot of antibiotics. It is the need of the hour. And believe me, I had to go through these slides. The whole night I was not able to sleep because there is so much of pharmacology which I had forgotten. And still you are practicing it. So we keep on learning, unlearning, and relearning. Very important antibiotic which we often use in daily practice, especially in our unit we use clindamycin quite a bit. So we will try to know in quick slides mechanism. It's a macrolide, lincosamide, streptogramin B. We will not go into this detail. You understand this. This is the channel. This is the channel, main channel. This induction of the ribosome, this induction of the peptide tRNA dissociation from the ribosome inhibits this protein synthesis. This is the nascent peptide exit channel. This is where it acts. This is very important. There is something called as a D-shaped clindamycin sensitive or erythromycin resistant. So what you see is this is a positive D test that is a blunted here. Okay. So if this is a growth like this, then it is clindamycin resistant or when there is no blunting. So the D indicates inducible ribosomal resistance. So if this growth is like this has to be blunted, then it is sensitive. If it is like this, then it is resistant. So positive D test in moderate severe MRSA infection, avoid clindamycin treatment. So clindamycin usually we use in gram positive only, except enterococci, excellent for pneumonia. We are using it, especially VAP associated pneumonia and beta streptococci. The action is bacteriostatic. It doesn't mean that it is not bactericidal. There is some overlap of bactericidal activity and bacteriostatic activity. Where we should not use it for intra-abdominal infections, especially when we are thinking of a bacteroid resistance. Dose 20 to 40 mg per kg, we divide it into 6 to 8 hours. Maximum daily dose is 2700 mg per day. Oral also clindamycin is available, 10 to 25 mg per kg divided 8th hourly. Clindamycin indications: soft and skin tissue infections, necrotizing pneumonia, toxic shock syndromes, osteomyelitis, septic arthritis. Uncommon when you have an anticipated penicillin allergy, recurrent tonsillitis, diphtheria, Lemierre's disease, gas gangrene, toxoplasma, and pneumocystis cabrinae pneumonia. Okay, and malaria. So clindamycin, what is the drawback? It is not available as a pediatric suspension. Fear of pseudomembranous colitis. Actually, it's only reported in the literature. We have not seen it. Not to be used for MRSA bacteremia. Got it? Then no gram-negative cover. So this is basically about clindamycin, but it is a very safe drug for gram-positive cocci. Now these are drugs. Phosphomycin, personally to tell you, I have no experience about phosphomycin. I too came to know about this when I was going through this module. Linezolid, yes, we are very much using, because we do have vancomycin resistant strain. We use a lot of linezolid, but phosphomycin is a new drug for us. We will just go through some very few slides. Another 5-6 slides are there. So a 6-month-old child has high-grade fever, 7 days, no obvious focus. This child was initially treated with oral antibiotics. She was admitted to us. These are the labs. She had a 12,000 count, high CRP. She had plenty of pus cells. She had microorganism present. So what was the diagnosis? Probably a UTI. This child was started on IV ceftriaxone at 100 mg per kg per day. So what is happening here? Urine culture, E. coli. We were right in our diagnosis of E. coli. So what is happening is, see here, ceftriaxone and this one, E. coli, and see here, colistin and phosphomycin. Phosphomycin, it is sensitive. Colistin, again there is a catch here. We need to be very careful. Are we dealing with upper UTI or lower UTI? Treatment options, left out is colistin, polymyxin, phosphomycin oral. Again,
they should have added some more things in that UTI. Whenever we are dealing with a complicated UTI, our game plan changes. When we are dealing with an uncomplicated UTI, the game plan changes. Or complicated UTI when we are talking of upper UTI. Uncomplicated UTI when we are telling is basically a lower UTI. So fosfomycin, what is the mode of action? It is bactericidal. So it disrupts the cell wall synthesis by inhibiting this enzyme. It is available as oral formulations. It is also available as IV formulations. I have really no much experience of using IV fosfomycin or oral fosfomycin. They tell it can cause hypernatremia and hypokalemia. The pharmacokinetics and pharmacodynamics exhibits concentration dependent killing with prolonged post-antibiotic effect. That's what we learned in Bhaskar sir's class today. Then bioavailability is very low when we are using oral, hence used only for lower UTI. IV formulation does not bind to plasma proteins, gets widely distributed in tissues, hence can be used in CNS infection, osteomyelitis, severe infection, yes, fosfomycin. I have seen using critical care people in MICU. Fosfomycin and polymyxin, both they are using it very often in our critical care ICU. It gets excreted in the urine by GFR without biotransformation. So what is the summary? Yes, it is used in the treatment of multi-drug resistance and extreme drug resistance. It is used for both gram-positive, gram-negative. All these organisms it can act, but it already has intrinsic resistance to Acinetobacter, Pseudomonas, all these organisms. Clinical indications, yes, it can be used as a monotherapy or it can be used as a combination. When we are dealing with a hospital-acquired pneumonia or a ventilated-associated pneumonia with SSTIs, osteomyelitis, meningitis, sepsis, monotherapy, this is very commonly used drug in our critical care ICU in adults. These are the pediatric recommendations. If we are dealing with premature neonates, it is 100 mg per kg. Neonates 40 to 44 weeks, it is 200 mg. 1 to 12 months, 200 to 300 mg. I have no much experience on fosfomycin. Now, as we are dealing with this child, we had very less option because it was resistant to all. The only option left was colistin, polymyxin, fosfomycin in that child, 7-year-old child. So we changed to injection fosfomycin, recovered completely. As it is mandatory for any child with UTI, we do a screening ultrasound. MCUG was done, which was normal. Used as a salvage therapy for MDR infections, or either as a monotherapy or a combination therapy. Okay. This is about fosfomycin. Now we come to the last drug for today's discussion, that is linezolid. Linezolid, we use it very often in our ICU setup and in our ward setup. We had a 2-year-old child who had a gluteal abscess. He had constitutional symptoms. He was earlier started on amoxiclav for 3 days. And he was done, 20 ml pus was done. Then what was, the pus was sent for culture and it grew methicillin resistant Staph aureus. Okay, and we have this MIC now there. So what is clindamycin? It is resistant there. What was the left out? Gentamicin. MIC was equal to or 4. Linezolid, the MIC was 2. We had ticoplanin, tetracycline and vancomycin. So among these, we chose the MIC, lower the MIC, higher is the sensitivity. What is the choice of antibiotic? If he is taking orally well, if his constitutional symptoms are less, Lizomed is the Lizomed. Couple of companies have oral Lizomed publications where syrup formulations are there, where 5 ml is 100 mg. It is available as oral formulation. What is it? Basically, it is an oxazolidine. It inhibits protein synthesis by interfering with translation. thereby decreasing the toxin production. It is bactericidal against majority of the streptococcal species and even also has bacteriostatic action along for staphylococcus and enterococci. It has excellent penetration in the lung, CNS, exhibit 100% bioavailability. Food does not affect the absorption. Plasma binding is nearly 31%. It is eliminated by renal and non-renal mechanisms. No need for dose adjustment in renal or hepatic this one. Then T half is 3.4 to 7.4 hours. It is a reversible MAO inhibitor. Spectrum of activity, actually it's a wonderful antibiotic. It is used very commonly for MSSA and MRSA. We use it for enterococcus, including vanco-resistant empyema, then enterococci, then we use it for group B, strep pneumonia, strep pyogenes, mycobacterial species, anaerobes, but it doesn't have any effect on gram-negative bacteria. Indications, yes, it is used in pneumonia, complicated skin, cough, soft tissue infections, bacteremia, then OAIs, oral infections, CNS infections, then febrile neutropenia, and it can also be used as a drug for multi-drug resistant and extreme drug resistance. But linezolid should not be used as a first drug. Again, what Bhaskar sir was telling, because linezolid is one of the anti-tubercular drugs which is used for extreme drug resistance for treating multi-drug resistant tuberculosis. So we should have an indiscriminate use of linezolid should not be used. Adverse effects, by and large, we have not seen any adverse effects with that. It can cause anemia, leukopenia. These are some of the noted side effects of linezolid. So applications of linezolid, it is used mainly in multi-drug resistant, extreme drug resistant, vanco-resistant enterococcus, complicated skin and soft tissue, hospital-acquired pneumonia because of MRSA, pneumococcus, uncomplicated and community-acquired pneumonia. So this is my last slide, and before we wind up, I would Cotramaxol open mat. It was not done, sir? This case scenario, fever with chills for 15 days, weakness, no response, febrile, no other findings, started on paracetamol, advised investigations. This had pustules of 50 to 60, and sensitive pattern was there, this was sensitive to ciprofloxacin and intermediate resistance, sensitive to cotrimoxazole, pelvic ectasia, right keeping highly diabetic, right urator, VUR done, grade 1 VUR. Started on, should we have used cotrimoxazole as the Klebsiella was highly sensitive to it. HIV is used. PCP pneumonia. Maybe it will come back soon because nobody is using it. You are using enteric fever, again it has come back. Yes, 10 mg per kg, 2 divided. 2 divided. It has come back. It has come back. We need to use it more often. So it is a good choice for salmonella infections, but nobody promotes it. We should do. Huh? Yes, sir. Yes, yes. It should start. Yes, yes. We can really start it. Sir, I once again thank all of you, and it was a very rigorous session from morning till evening. Once again, I thank the IIP office bearers. Very quickly, we can have a 5 minutes feedback from the delegates, and then we wind up 40. No, sir. I'm also a part of it. You can give the mics. No, it is incomplete without asking the feedback. Finish it properly. Anybody wants to give the feedback? Sanjay is there, pulmonology head, you can speak.
Sir, it was really educative, especially for the postgraduates. Most of the things we are doing, but unknowingly we are doing some of the things. So at least they know what it is.